Morena, mi karakia tātou, whakataka te hao ki te uru, whakataka te hao ki te tonga, kia mā kina ki utu, kia mā tara ki tai, ehi aka ana te atakura, te ho he hoka, he hu, te he Māori ora. Morena, haere mai to our third PHONZ Conference. It's wonderful for you to be here. We'll just hand over to Barry to welcome us all, and then we'll get started. Over to you, Barry.
Thank you, Tim, and good morning, everyone, and welcome to the second day of the PHONZ Conference. We had a great response yesterday of some highly interesting speakers and presentations. And once again, on behalf of the PHONZ Committee, thank you for your attendance and support of PHONZ. I'll now pass back to Tim, who's going to be chairing the first session. Thanks, Tim.
Thanks, Barry. A bit of a yo-yo to start the morning off, because in a second I will hand back over to you as yourself and Chris are our very first speakers, heading off the session titled The Future of Health Intelligence. So Chris and Barry are both fellow committee members for PHONZ. Chris joins us from the UK, and Barry is on the lovely Kapiti Coast. So I'm not too sure who is going to start, but I will hand the floor over to you.
I think it's up to me. Barry's going to be the silent partner. He might chip in when we get going. And you can see my slides?
Looks like it's just loading up. There we go. Good to go.
Excellent. Okay. Great. Good morning, everyone. In New Zealand, it's evening here, and it's a traditional UK summer, which is something like the New Zealand winter, wet and rainy. And I've got a lot of rain coming down. You can't hear that because I've got a good microphone, but hopefully I won't fade in or out. Barry and I have been having an ongoing conversation for a very long time about what is the future of public health intelligence? What problems are we trying to solve is probably my favorite mantra over the years. What we're going to do tonight is we're going to have a little bit of a story, and we've got 15 minutes, take you through a journey of what I think the future might look like for us, as I currently work for the Department of Health in the United Kingdom. I used to work for the Ministry of Health in New Zealand. I've also worked in Australia, both for the Queensland Health on contract and also in the biosecurity sector there. Prior to all of that, I did work in the Canadian Civil Service for a few years, mainly in the environment and earth sciences area. So I've had a bit of an experience of how public sectors work. I can tell you that all the mistakes that you're making in New Zealand, we're doing it much better in the UK than you are. Much better mistakes, I mean. And so let's go and have a look at what our future, our joint futures might look like. One of my favorite science fiction writers is a fellow named William Gibson. And he has a quote which really resonates with me and the work I'm doing and looking at the future. He says it's already here, it's just not very evenly distributed. And this really says two things. The first thing it says is that there's hints of the future in what we're doing today and what people have done in the past. We just need to look for those things that we think have got legs, and that these signals will tell us something about how patterns will emerge. And the second thing that this tells us is that it can be very frustrating, that you might be ahead of the curve and being held back by the structure of the current present time and the way we do things. So it can be a bit of a curse to be a bit ahead of the curve, but looking at it is a way of trying to create the future that you want. And I think if you don't create the future that you want, somebody's going to do it for you. So that's why we spend time doing, well, in the UK, we call it foresight, but the Americans call it futuring. Okay. So let's start with our past. Now, this fellow probably won't be as well known to you as Jon Snow, who was on my opening slide. But he was a contemporary, a friend, an intellectual equal in many ways. And this conversation that he relates with a medical friend of his, Dr. Snow's views on cholera, said a medical friend to me in 1855, the year after the purported incident with the Broad Street pump, are generally regarded in the profession as very unsound. Okay, so we often think of John Snow as somebody who started epidemiology, the modern thing, and he got everybody going. He was well derided during his that period in time. His report was dismissed at the time, and he only achieved anything, I believe, because Henry Whitehead did his own study in response to the negativity that John Snow was getting, and was able to show from his interviews, he went and interviewed lots of people in those neighborhoods, Soho, that in fact John Snow was right. And it was only after that that the medical commission of the time approved John Snow's report by one vote. Okay. So he was saying that really maybe the medical profession should take a little bit of medicine that they give out to people in the church when it comes to regard to heretics. Okay, he's saying maybe we need a few heretics in here, people who aren't thinking like the herd. And this is a kind of a funny story because of what happened to me in the last couple of weeks. So last Monday, I got this text message. The National Health Service now is fully digital. And this text message says, please note that due to unprecedented levels of staff sickness, there'll be a significant delay in answering any calls to the surgery. This is my general practice. 14 doctors, 3 or 4 admin people, 3 nurses, a phlebotomist, and a pharmacist. We therefore kindly ask that you only call if your need is urgent. I mean, why would I be calling if I didn't have an urgent need, right? I'd call them up for a chat or something. I don't know. We appreciate your understanding and patience at this time. Now, this wasn't a long time ago. This was last Monday, right? Monday the 15th. And then Wednesday of last week, we continue to be short-staffed. Now they're fessing up that they actually have a COVID outbreak in their practice. And it's affecting a number of our reception team. That's interesting. They got 20 people there, plus a full waiting room. It's only affecting the receptionists, apparently. We request that you only call the surgery if it's urgent. And there may be longer than usual waits for prescription requests. So they're not even fulfilling prescription requests at this point. This isn't the pandemic. This is last week. And then finally, on Monday of this week, unfortunately, we continue to face significant staff shortages due to a COVID outbreak in our reception team. Only call for urgent matters. I mean, people don't call because they just want to have a chat, right? This is the National Health Service 2 years after the response to COVID ended. So I'm thinking here, what about ventilation? What about the air filtration that they used to have and turned off? Anybody thinking about wearing masks? Okay, so that's how we're going to start. That's how we've connected John Snow to my current GP practice. There's something wrong here and nobody's speaking up yet. So let's dive right into the current. So I'm looking at the future, and I've used some AI tools. I've done some horizon scanning, and I'm pulling out the things that other professionals believe are driving their future. And we're part of the future, so there'll be drivers of public health intelligence. We're going to start with planet Earth. Then we'll look at some of the drivers that are in human society, so a subset of everything that's happening on the planet. Then we'll look at health systems, and then we'll look at public health intelligence. Okay, so planet Earth, what do we got going on? Climate crisis, right? Global heating. We've got human pollution, not just CO2, but we've got microplastics, we've got pesticides, we've got ecosystem collapse that's resulting. What's happening in humans? Got this rise of new oligarchs, techno-feudalism, if you will, billionaire class. When people talk about the billionaire class. And this is driving global economic inequality between countries, within countries, everywhere. The same time that we have this increasing economic inequality, we've got rapid urbanization around the world, and we've got collapsing birth rates. Okay, so what we thought was going to be an overpopulated planet, we now think will probably peak sometime this century, and some countries are in real trouble. China, South Korea, Japan, Germany are all well down the track to depopulation. What else is going on? We've got, as a result of this, multiple workforce pressures driving immigration policy. Now, this is resulting in some political polarization in the UK, in America, and other places around the world, declining public trust in the system as a result. The health systems, as a result, are having some really interesting problems. So the increasing economic inequalities driving health inequality. Our year-on increases in longevity and improved health around the planet is now slowed right down and has stopped and is reversing in some places. I think for the first time ever, the UK is now seeing a decrease in life expectancy. The improvements of the mid-20th century are no longer the improvements of the 21st century. And this is terrifying for a lot of reasons. We're starting to blame things like the aging population and obese people for the new rise, the new problems, the chronic disease problems. But that can't be right. It can't be those things. What about the food systems that are creating this problem, or the poor housing, or the lack of meaningful employment, creating poverty and inequality? So the response from health systems is more preventive and proactive approaches, the digitalization of absolutely everything for efficiency gains within a system which in itself is kind of collapsing because there's no money left in it. It's all owned by the 1% now. I think in the UK, the 11 richest people have the same wealth as the 70% of the bottom, right? So, I mean, these are extraordinary figures of inequality that we haven't seen since the very early 20th century, the robber barons, the Rothschilds, and so forth. So when we get down to the intelligence system itself and how we do our work, we're faced with rapid digitalization, and the development of AI is everywhere and in everything these days, because everybody thinks it's going to offer solutions to our workforce crisis, which is that we don't have enough people, or we can't afford to have enough people to do the jobs that we think that we need to do. So we're being pushed to centralize data, to link data sets, all because we can apply AI and because we can get efficiencies out of this. So these are the drivers. They can be pretty frightening and pretty confusing all up. But there's a tool that I found, one that's quite popular in the UK. Bill Sharp, a UK futurist, has developed it. It's called the 3 Horizons model. And it's got a X horizon, which is time. And it's not linear. It's just a notional diagram of how things are proceeding. And the Y-axis is about what's occupying our time. What are we doing? What are we thinking? And he's got 3 lines on this graph. The blue one, Horizon 1, is about the present and the past. And it dominates our thinking today. And then the next set of activities, a little bit further down, harder to see, are those that are going to take us into the future. And then the bottom horizon, Horizon 3, is the desired future. And this is the one that you have to work with your colleagues to try and get a sense of what do you want from the future. And I think what we're really looking for in the future is something around public health intelligence helping to solve problems, right? To be the facilitators of problem solving in organizations. So if we go through this in a little bit more detail, I'll take each of the horizons in turn, then we'll have a better idea of where I think we're going to go based on what I think we need to be, where we need to be, which is Horizon 3. Okay, so let's have a look at our past and our present. The picture on the right-hand side is one of 7 Nightingale hospitals built in the UK for the COVID pandemic. And you're looking at an image probably of its peak usage during the pandemic. They weren't used. £500 million was spent on that. Now, why would you build these massive auditorium-like hospitals for overflow sickness? Because you're thinking of 1918, right? That's the only reason that you would build something like that, because we didn't have any staff for them. We're running out of max capacity in our hospitals, so 90% capacity all the time. Where would the staff going to come from? What's going on here? There we go. We're trapped in old thinking. This is the problem that we're having in every area of our health sector. We are limited by 19th century management paradigms, things that were, top-down hierarchical organizations were created for the Industrial Revolution. We focus more on data than intelligence, those little bits and pieces that we extract value from at our own peril. Could you imagine anybody progressing beyond development of the Iron Age if all they were focused on was iron ore and not actually smelting, creating steel, right? We're siloed and we're fragmented in our approach to almost every challenge we can think about. Obesity, diabetes, CVD, smoking. All these are separate programs in public health, but they're all the same program, really, aren't they? They're all interrelated. And we still don't have organizations that actually learn. All the learning is done by individuals, and when you leave the organization, you take the learning with them. Put your hand up if you've never worked in an organization where you said to yourself and your colleagues have said, haven't we made this mistake before? Haven't we been here before and done this? Right, no hands. I don't see any hands. So I'm assuming that almost everybody else has seen that too. 230,000 folks. That's the official death toll, 2 years. Okay, the number's still going up. And in fact, the rate of hospitalizations this week in the UK are over 5 times higher than the same week last year. In summer. Okay, so this is pretty astonishing stuff. Where we need to be. We need to really radically rethink the way we organize ourselves. We need to be fully integrated and have coherent approaches that pull in all sorts of people. We need system-wide problem management. There's no solutions anymore. We know that. Seamless, real-time intelligence sharing. Not data sharing, but intelligence sharing. How are we going to get there? First of all, we need to make a gradual shift. These things aren't going to happen overnight. So AI-powered open data, like Professor Ben Goldacre was talking about yesterday, that's what people are chattering about now as possible and doable in the next year or two. Cross-functional teams rather than silos of people who all look and sound the same and think the same way and have the same perspective. We need to move to co-creation. That is working together with people who need what we've got. We can't just sit over here and throw data over the fence. Okay, we need to actually start working with our decision makers much more closely than we currently do. They're part of creating the intelligence. We do need system-based practice. I mean, that's something I go on at ad nauseum, but it's true. And these are things that are happening all over the show, pilot projects everywhere. And lastly, the focus on inequality. The root cause of virtually all of our problems in public health are that we have vast inequality in our society. If we do this, we can increase our effectiveness, the effectiveness of our teams, our organizations, and so forth, so that we can manage problems, not trying to solve them, manage problems despite the growing complexity that we all see. And I'll leave you with a quote, because I started with a quote. I'll misquote Karl Marx. How about that? You probably haven't seen that in a public health intelligence presentation. He was talking about philosophers, of course, but I think it applies. Public health intelligence has only interpreted the world in various ways. We're describing things. The point is that we're supposed to be changing things. We're supposed to be helping our wider organizations make change. And we really aren't doing that yet, not just by throwing numbers over the fence. Okay, that's what my look at the future and my conversations with Barry have delivered up for us tonight. Thank you very much.
Mihi, thank you very much, Chris. That was really insightful. Nice reference to John Snow and the heretics side of thinking, and then I liked how you brought in the new way of thinking and how hard it is to pull away from that old way of thinking. And given our latest health reforms, I see that happening very, very often. And I'm sure you saw it as well when the UK changed their health system just recently also.
Yeah, still doing it.
Yeah, we have plenty of time for very difficult questions for Chris and Barry. So please, if you've got any questions, feel free to use the chat or put up your hand and we'll unmute you.
Everybody's quiet.
Right. I do have a question, Chris.
Okay.
And it's around timeframes. Obviously, what you're discussing doesn't happen overnight. But do you have an idea of, how long we should be taking to make significant changes within the system?
Yeah, that's a really challenging problem, and I think Barry would probably have a much better view of how long change takes in the New Zealand system today. I thought it would be harder to make change in the UK, and to some degree it is. We have over 10,000 analysts in the health sector. But actually, it's probably just as difficult as it is in New Zealand in some ways. I think the thing that's moving along really fast is the AI. Out of all proportion to problem solving, we now have to deal with machines that are telling us fibs.
Yes.
Yeah, I think there's a question just come up also, Tim, of the difference between intelligence and data. And well, Chris will know, and most of the PHONZ people know, this is a particular hobby horse of mine. And I think it was great to see that Ben Goldacre actually referenced this as well. And I think that one of the things is in New Zealand, historically, we've collected truckloads of data. I always say truckloads of data. And I think the one thing that Goldacre mentioned yesterday, it's raw data. And what we actually need is some humans that actually can do something with it. And even AI is not going to, as Chris said, AI is not going to solve the intelligence problem. It's a tool to actually help us do stuff, but we still need human beings to actually be that interface again. And I think also we can train analysts to do mostly think. But the other part of it that's been lacking, and often in New Zealand, is the fact that we need people higher up the chain, the managers and so on, to actually think intelligence and not data, spreadsheets, graphs, and so on. I think that's a coming together. We can actually train, if you like, analysts to be intelligence people, but I think there needs to be a top-down reverse thing to actually put in place people that can actually ask those leading questions. What is the intelligence? The so what questions? I think it's very easy to give information out to people, very difficult to ask the so what question.
Can I also add that for the information scientists out there, data's at the bottom of the pile. It's the iron ore that we then smelt into information, which is structured data that can answer questions. And then that once you've got that, you can use the information to do things, then you've got knowledge. Now, intelligence is somewhere in the top two of those things in response to it's information that you're applying to address a specific question or questions or some tactical posture that somebody's got, and they need information that's relevant to what they're doing. That's intelligence, in my view.
We've got two people with their hands up who have got questions for you. And we'll start with Amanda. I think you've got a question. You should be able to unmute yourself now.
Yes, kia ora. Can you hear me? Yeah, kia ora, Chris. A really great presentation, and sort of picking up on what Barry has said. Any thoughts on really resonating with that thing of your graph about the kind of the future state and the current state, and Any suggestions about when you have health organisations that are very much stuck in their traditional paradigm, how you kind of generate changes there without that being seen as threatening? And I'm thinking public health intelligence versus data in this case. But yeah, just and the COVID pandemic being a spectacular example of how information isn't actually driving change in practice. So yeah, any thoughts on how you influence those sort of new ideas when you've got very trenchant management systems? Kia ora.
The really superficial answer to that question is contained in a movie that Brad Pitt did that I really love called The Fight Club. And the first rule of Fight Club is that we don't talk about Fight Club. And I think people are threatened about talking about the future or systems thinking. They don't get it and what's wrong with what we're doing. So I think you need to talk about things that resonate with your audience. So that's why I've talked about effectiveness. I think almost everybody will agree that having a more effective organization or a team is a good thing. So a little bit deeper is to involve them in activities like Three Horizons workshop, where they can begin to be part of the group that defines what a desirable future looks like. And that fits into strategic planning. It fits into all sorts of activities in which people can feel that they're actually part of the activity that's doing the understanding or the developing a shared understanding. Involving people's the best way.
Yes, totally agree. Chris,
Can I just add something to that is that one of the things that came out of last year's PHONZ conference was a presentation by John Battersby, who Chris's colleague, in which John gave us a very detailed description of the training program that is used in the UK for training analysts, health intelligence people. And yet in New Zealand, we do not have, no university does anything with public health intelligence. We teach people courses to, well, now running AI, but where does a person that wants to get into public health intelligence get their training from? They actually get training from the people that are actually, as Chris would say, in the paradigm. And so we give them the tools, AI and so on, but we don't give them the thinking, how do you interpret what it is that's actually important? And that's the future.
And Ben Goldacre said that that's still the same problem in the UK analyst sector as well, health analyst sector.
Great discussions to kick off the morning. I am a stickler for keeping to time. I see that, Oz, you've got your hand up. Maybe if you could put your question in the chat, then we can answer them through there and keep that discussion going in the chat. I know our two next speakers are very busy people, so we'll try to keep on time. Our next presenter is Juliet Rumball-Smith, who is the Director of the Intelligence Directorate within the National Public Health Service since August 2022. Juliet is a public health physician, was the Clinical Chief Advisor for Primary Care at the Ministry of Health and Clinical Lead for the COVID Vaccine Program. Various roles including WHO, founder of the Wahine Connect Charitable Trust, and was a medical officer of health in Northland District Health Board. Juliet lives in Wellington with her whānau, husband and 4 children and 2 dogs. Juliet, the floor is yours.
Kia ora all. Thanks very much, Tim. Can everyone hear me okay? Double thumbs up. Yep. Awesome. This is cool. I'm really excited to present today. Tim, I'm going to share my screen. Can you just let me know if it doesn't come through or any problems? Yep. Can you see okay?
I think it's still loading up. There it is. You just have to start the slideshow.
Are we all good?
Perfect.
Fabulous. Tim, can you please keep me to time?
Yes, will do.
because I've got lots of slides and I don't want to waste
Yep.
anyone's time.
We'll give you a
Awesome.
bell at 5 minutes and 2 minutes.
Cool. Well, hello friends. It's great to see you all and thank you very much for the invitation. So what I'm going to talk about is a task I was given about 2 years ago, which was essentially around establishing an in-house operational intelligence directorate for the National Public Health Service. Now, I was pretty precise about this title because there's lots of public health intelligence whānau already existing. So, it's nothing new. We've got lots of expertise, but this was the task that I was given. In terms of the context, the reason is because we had this massive health reforms and that established the National Public Health Service and it established the Public Health Agency. And so there was a sense of kind of not starting from scratch, but like designing a new entity from scratch. And it was pretty exciting that public health intelligence got such a big profile in the reforms. So from there, August 22nd, I came into the job and I was the only person in my directorate and, it was a tricky time. So in this presentation, I'm going to describe a little bit about the journey that we all went through in it and some key takeaways. So the first takeaway that I wanted to share was essentially, and this is 2 years down the track, right, was, first tidy your room. And so what I've done is had a kind of unrelenting focus on the foundations. And by foundations, I mean, what are the core and critical public health intelligence products and services that we need to provide in NPHS? And how can we fill gaps where a service has not been? And how can we make sure that we're doing our best to ensure that everybody has access to high quality, accessible and interpretable public health information? And I use information on purpose because even though the goal is intelligence, I'd say that the foundations is good, solid, accurate information. So I'm going to give 3 case studies. So the first is about surveillance, and I'm kind of talking about communicable disease surveillance in the first instance. So how we started. We had 12 public health units. We had a variety of different ways of doing communicable disease surveillance. And this is in the context of ESR that really is our lead expert provider in this area. There was no standard BAU way of presenting communicable disease surveillance to the decision makers there. There were no protocols or response templates that was consistent across. We had different public health services. Some of them had 3, 5 surveillance analysts. Some of them had zip. There wasn't a consistent way of sharing or integrating processes, even though borders are arbitrary, right? And communicable disease spreads. We had some places that had extraordinary GIS expertise. There was a lot of duplication. We've done a stock take, 84 different surveillance products around communicable disease, and the hardware, software, data access piece was just heartbreaking, really, to see the barriers. Nationally, really interesting situation. When I came in, there were 11 contractors. All they did was report COVID-19. So that wasn't sitting with ESR at that time. We've gone from 11 to, I think, a core team of 4 to 5 permanent staff in NPHS intelligence, and we're aiming for all hazards. So a massive change. We had no formal rostered on-call service. There was no visible integration or sharing national, regional, local. No consistent or reliable product collated to senior stakeholders. My boss didn't get anything consistent, and ESR were really working triple time to serve a lot of different stakeholders. So we did an assurance audit. What you can take from this in that heat map are 4 regions and the national function. And what you can see from that is there's some real bright spots there, some places that were just doing excellent exemplar work. There's also some gaps, some red. So we set about doing a get to green plan, and the impetus was that I was really nervous about measles. We had about 7 incursions last year. Interesting how it all comes real and it's your name. And I want to know that we had a solid BAU surveillance, communicable disease surveillance for both our normal BAU and in the context of response. So we did a whole heap of work focusing on people, platforms, processes, and products. Now what we've got is an integrated networked team. So we've got we have 4 named regional intelligence surveillance leads. So that was even a bit of a feat. We have a designated national team and they work together as an integrated team. We have surveillance portfolios for clinical, for our improvement of performance team, Hauora Māori Pacific. We have an evidence portfolio for CD surveillance, and we've got good close relationships with the PHA. And you'll see Christie coming up next. In terms of processes, we now have a standardized process for multi-agency input, templated products. We've got a national, regional, 2-way information sharing forum. We've got escalation pathways, done a massive amount of learning and development, and we finally have standardized tools and processes, SOPs and SIP reps. We've got an on-call team. We've created a few foundation products. So you'll see COVID wastewater up there. We've got a weekly multi-agent surveillance product that gets disseminated out. We've got response templates. So none of this is rocket science, right? So it really was about foundation. Next case study, More Wilsons. More Wilsons is a super flash supermarket here in Wellington. It's where everything costs triple. It'll make more sense. Basically, we were doing some really cool work. This is an example of a dashboard that we've created for immunisation. It is extraordinary, the knowledge that we have about immunisation. No, I went to Singapore. I was like, we know a lot about IMS. And they're like, why? Why do you need to know so much about IMS? Everyone gets immunised here. I'm like, right. So we have just such granular detail about immunisation. We sent out this awesome dashboard and people are like, looks good, can't access it. Pretty crippling, really, to hear that sort of stuff, not only from people outside, but from my own kaimahi and my own team. So we kind of did a bit of a deep dive to understand what life was like for our analysts. And these are just a bit of a storyboard. So we've got clear. You won't be able to read this, but essentially all those steps are the things that are required to assemble a report. And it was just a misery-inducing manualized process that at the end of it, people like me were like, why is there a mistake on the 3rd line? It was just a really difficult time. So a key part of our tidying our room was to focus on the foundations about the infrastructure. So this is just one snapshot of it. 278 tickets to the service desk. We tested all the apps and the software. This is all pre-migration and migration. This isn't even about getting people onto a Te Whatu or an email address. It was about being able to share the data, share the software. In the end, we just sent out 28 laptops. And so we're talking about real workarounds. I'm not certain that people know that we did that, but we did that. And it was really hard work. 9 kilos of chocolate for More Wilson. It's personal expense. Te Whatu Ora didn't pay for it. Because people really did go the extra mile on doing walkarounds training. So it's just a bit of a snapshot of how tricky and manual some of this stuff was. Next case study, one team. So in Intel, essentially what we were doing is bringing together teams from Te Herenga Hauora, the promotion agency, multiple districts, because remember regional teams didn't exist at this point. And of course, supporting the people who'd been on the COVID journey, just because they were contractors or fixed term didn't mean that they hadn't really been doing a solid. So as one of the key things that we did, and it, tangible stuff counts, things like chocolate counts, is that we focused on trying to make us feel like one team, so working together. So we created a front door. This is our intelligence front door on our SharePoint page. And a big part of it was this box on the right that was, this is how you access Intel. And this is not only for Intel people, but for NPHS. So we did an initiative called the Great Funnel. And what that was about is one way that you could come through to the NPHS intelligence team so that we could start to match requests with skill sets, irrespective of where they were sitting. So a huge amount of work. There's a technical solution behind it. There was training behind it. And from this, we'll be able to understand what is it that people want from us. Because we get ad hoc requests from all different parts of the country, and you're like, oh, actually, 7 of them are the same. Maybe what we need to do is create a product. So there was a bit of a culture stream. You'll see Chris McDowell there with our intelligence mug. We did some merch. We did a whole heap of training. All those trainings there, that was just in 2 weeks. So that's real people doing this on top of their work. So big shout out to all the kaimahi who were involved, and a big lift was done on this by our regional folks. This was all about addressing where we wanted to get to in the end, which was that we utilize the diversity of our skill sets, and we to enable equitable access to that skill set across the country.
Ding ding, that's your 5
thank
minutes
you.
now.
Okay, my final takeaway was, honestly, I knew nothing. I thought I knew stuff. I knew nothing. Like, I have waken in the middle of the night sweats about the things that I thought at the beginning of this process and actually how it turned out. So really I was lucky to come in as only one person with no team, because what that meant is that I had to do 3 months of chatting and exploring with everybody in it. And we did a really fulsome exploration period. We did interviews and workshops and literature reviews, and that was really fortunate. And I look back on it and I think, so this is our success framework. I would never have known how important that the partnership was with data and digital had I not done that exploration. Equity and fertility would never have been so central in our work. We've got a kitty, a whole development program, if we hadn't done that. So what's next? Cool stuff. Reconciliation. We're building a data warehouse. This dashboard here, that's in Tussis, that's for Northern, that's rolling out to everybody, because we can do that because we've got the infrastructure. These are just some of the cool visualizations that we're doing. Our equity toolkit. We're thinking about how we present our intelligence in a way that's accessible. Maybe it's talking heads. I don't know. But yeah, watch this space. Linked data sets. Over.
That was absolutely wonderful, Juliet. Thank you very much. Nice that you mentioned equity in there, and that is such a key component of your work from the start and also going forward. So thank you so much. Yep, I remember when beer was sort of the payment for favors. Nice to know it's switched to chocolate, which is probably a bit more healthier.
And mugs.
and mugs. Yeah. We have 2 minutes for questions. If there's anything in the chat or any hands up. I see there's one question, Juliet. How close to your aspired model are you now?
Yeah, so thanks, Paul. We track it. So, long story short, but essentially we work in 3-month sprints and we track it every 3 months about how we're going along at those 5. Yeah, we're doing really well. And so I would say this focus on foundations, lots of it, that's quite invisible. Like you can't, it's quite hard to give a snapshot of a Snowflake data warehouse and send it out. But I think that the next 3 months and the 3 months after that, you're going to start to see a lot more coming from Intel, partly because I know it feels boring to tidy a room, but it's really hard to get anything done until it's sorted. So yeah, I think we're doing well. I feel really proud of the team. Got great people.
Yes, yeah, there's a lot of work that goes behind those dashboards and the outputs that
Yeah.
that you do. So yeah, a huge thank you to you and your amazing team.
Kia ora.
Thanks, Juliet. Our next speaker is Christie. Are you online, Christie?
Yeah, I'm here.
Nice, wonderful. Welcome. Haere mai. I think, is this your first PHONZ conference?
Yes, it is actually.
Nice. It's great to have you here. Christie started her career at the University of Auckland, becoming a senior research fellow, and has had a number of public sector roles, including the Department of the Prime Minister and Cabinet, and Te Puni Kokiri. In March 2024, you joined as the Group Manager for the Public Health Agency's Intelligence, Surveillance and Knowledge Team, otherwise known as ISK. So welcome. I will hand the floor over to you.
Awesome. Thanks, Tim. And thanks, Juliet, for an awesome presentation, which hopefully I will build on now. Is that showing up?
Yes, I believe so, but it looks like we're in not in the presentation mode.
Oh, it's just in a PowerPoint. I mean, in a PDF.
Cool.
Got a PDF.
Looks good.
All good? Awesome. Cool. Thanks. Yeah, so building on Juliet's presentation, hopefully. I know in my short time in the Public Health Agency, we've really strengthened the connections between PHA and NPHS. So that's been really cool. And actually, I've been missing Juliet. I haven't seen her for a couple of weeks, and we went through a stage of meeting daily. But that's a really great aspect of our work, and that we are really working closely together. And hopefully I'll also be able to respond to Michael's question in the chat and Chris's comments around how we bring surveillance and intelligence and align that and strengthen that through decision makers and governance. So this is some work that we've been doing. The PHA has been leading on the Public Health Surveillance Strategic Plan. The team started this late last year, and Tom and Vanessa are on the line if you have any tricky questions. And we've really ramped it up, and we've actually got a plan now, and we're going to be publishing it in the end of the year. No, end of August, towards the end of August. So in essence, what the Public Health Surveillance Strategic Plan is, it's designed to strengthen our public health surveillance system to support the increases in life expectancy, improvements in the quality of life for all of our New Zealanders. It's the cornerstone of what we think is public health. In practice, uses data intelligence systematically to inform timely decision-making in public health action and response. The strategic plan sets the direction for strengthening our public health surveillance system. The PHA primarily led the development of the plan, but we've had a number of working groups and leadership groups across the PHA, NPHS, to Te Aka Whaiora when it was in existence, while still retaining those connections now, and as well as ESR. So they're really the key players that have been that we've been working with to develop the plan. But we did go out for quite extensive engagement on draft versions of the plan, and we received a lot of feedback from a lot of people who are hopefully on this call as well. So in essence, what we want is to be building a system that's organised, is high quality, effective, equitable, culturally and ethically sound, and one that recognises the One Health approach, so human and animal health are interdependent, as well as keeping Te Ao Māori and Te Tiriti at the forefront of our mahi. So this is just an example of how the public health system is really broad, in the different data and information that is brought into surveillance to create intelligence is varied across the system. It's not just the public system. We've got our academic friends, we've got ESR, as Juliet mentioned, is really integral to how we are focusing on communicable disease, where the risks are, horizon scanning. So a lot of these are sort of generic, but we also obviously have some important different types of data and sources for specific diseases and focuses. So, I mean, just generally, this is sort of how we think about the public health surveillance cycle. And this is all sort of, as I've mentioned, embedded in a public health intelligence framework. And so we are, sorry, I've got a bit of a croaky voice, how we bring in the data and intelligence, and then how it's disseminated out, and then how it then feeds into actions and response is really important. And so we need that to be connected across the system and have those close connections, and that will become really clear in the directions that we have come up with. So as I mentioned, the team, we did really rigorous collaboration and consultation on various drafts of the public health surveillance strategic plan. And we really used this information and the feedback from that consultation to help us develop 5 strategic directions. Maybe there probably are 7, but 5 strategic directions to really sort of form the foundation, the PO of what we think is a gold standard public health surveillance system. So I'll go through each of these in turn and just talk a little bit about them. There's a lot of information on the slide, so please don't read them. We'll sort of, the document will be published soon, so you'll have all of that information at your hands. The first one is really key and sort of does build on both what Chris and Juliet have previously talked about, and that's governance, leadership, and coordination. What we really need in that space is excuse me, is to establish enduring and sound and coordinated governance and leadership system that has a sort of an intentional approach to surveillance. And so we're all working, singing from the same song sheet, and we're all working on the same priorities. So what we need is really, and what Juliet and I have been doing actually is really trying to get clear on what the different roles and responsibilities are of the different players in the public health surveillance system, and who's accountable, who's responsible, and then how do we work together in order to deliver on that surveillance. A lot of it is about information and data and information and how we can connect across the system. And the first, I guess, our first port of call is really thinking about the first action that we're progressing is really thinking about how can we develop a governance model that sort of sits across the system. And so this is still to be operationalized, but what we're sort of working towards is we have the Shared Public Health Leadership Group, which sort of sits across Te Whatu Ora, PHA and NPHS, obviously, and they provide the overarching oversight of the surveillance system and direction setting. And then there's a surveillance leadership group that sits underneath that. That's basically sits across ISK, the Director of Public Health, and NPHS. And then we're trying to create a system where we're not duplicating and we're working together, as I mentioned, on those common priorities. And so how do the Ministry of Health and PHA's priorities sit alongside NPHS priorities? And then how do they sort of feed up into this sort of overarching governance structure? Still a work in progress, but Juliet and I are working on it, and I think we've made a lot of really good progress over the last few months. And obviously, how do we bring Māori into this picture? Bringing in the information from the ground, from the iwi Māori partnership boards, from different Hawara Māori providers, and our key stakeholders across our agencies is really key. So reflecting that is we've really tried to put Te Tiriti or Waitangi up in highlights, and we really respect and we really want to ensure that what we're doing in public health surveillance is promoting Te Tiriti, the principles of Te Tiriti and Māori leadership. And so that's why we are very, very consciously working on how do we bring the Māori voice and leadership into the governance structure. Another thing alongside that is actually, obviously, it's about surveillance, but it's about getting information out to communities so they can develop their own intelligence around what is happening and develop their own responses, and how do we support that. And up alongside Te Tiriti is focusing on equity. How do we ensure that public health surveillance has the right attention and investment that is directed towards advancing equity? Equity is really important for our public health priorities. There's a lot of work that still needs to go on in order to ensure that we are focused on equity, and part of that is about actually data, collecting good ethnicity data, good population data, and focusing on our underserved populations. And then how do we share that data across as well? Coming up to, I guess, the strategic direction number 4 is focusing on emerging public health challenges and priorities. And so that's responding to new threats, to new opportunities, and it's really taking that horizon scanning approach. And ESR is really integral in that, and looking, and what we do in ISK is look abroad, what's happening abroad, what do we need to be doing to be ready for any new threats? As Juliet mentioned, how are we ready for a new measles epidemic if and when it starts? What's the intelligence functions that are needed in order to help us to respond to that? And finally, the last one is it's about continuous improvement. So it's never going to be perfect, but how are we looking to continually to grow the system, to continue to develop that system, as Juliet said, grow our data and information systems, how we're monitoring and evaluating what we're currently doing, as well as identifying gaps and opportunities. And so we're really keen over the next 12 to 24 months is do some deep dives into some specific diseases, looking at maybe RSV and what does a good or influenza-like illness, what does a gold standard influenza surveillance system look like? Where are we currently? What do we need to do in order to get there? And doing that across PHA and NPHS and ESR. So that's pretty much where we're at. We are intending to publish the plan towards the end of August, just going through the sort of publication process. As I mentioned, our first sort of cab off the ranks is establishing the Public Health Surveillance Leadership Group. And thank you. And we're working on improving our data and information systems, because that really does underpin our public health surveillance and intelligence system. Also building on the systems and processes that were set up during COVID-19, how we're using wastewater testing and whole genome sequencing in our public health surveillance system. So that's pretty much me. I think I was to time. Stop sharing.
Yes. No, thank you very much. You're absolutely perfectly on time.
Awesome.
And it's really interesting to see what you're doing in ISK.
Yeah.
And looking forward to the future to see how it all unfolds and unravels.
Yeah, cool.
We have
hopefully it doesn't unravel.
Well, good things. We have 5 minutes for questions, and we can always go into our break if there's good discussion. So open the floor to questions via the chat or the Q&A, or if you put your hand up, we'll unmute your mic and you can.
There are 2 questions, Tim. One from Gerald Sonder and one from Hilary Sharp, if they want to ask. You want me to say them? Gerard, are you there? Oh. Okay, I'll read it out then. How do all these plans that still have to be developed relate to the 1.4 budget, 1.4 billion budget cuts that are mainly focused on saving frontline staff and all the MOH staff that have been laid off? Do you want to defer that to the Minister?
Yeah, great question. Yeah, I can't really respond to that, but all we're doing is trying to work, I guess, trying to look at efficiencies in the system and work better together and work better across the system. So that's, as I mentioned, that's PHA, that's NPHS, as well as ESR. So there's a lot of work that we're doing, particularly with ESR, to look at what are the priorities and where do we need to focus rather than doing everything. Can we focus on a few things and do them well?
Hilary Sharp has a question for both Juliet and Christie. How do you ensure work to strengthen NCD surveillance isn't overshadowed by urgent communicable disease work outbreak responses? The perennial problem.
Yeah, the perennial problem. Well, our surveillance plan, surveillance strategic plan, it is mainly focused around communicable disease and notifiable disease. We have other mechanisms for, I guess, monitoring NCDs through my team's sort of insights and impacts function, as well as through the broader PHA as in the Ministry of Health. So we're not ignoring them, but the stuff that I've talked about today, and primarily Juliet, is that reactive, communicable and notifiable disease.
Thank you very much, Christie. I see there might be one more question.
Oh yeah, Gerard's got one around ILO surveillance.
Yeah.
Yes, so there's been lots of work done previously on surveillance systems that I know Michael's done, and Gerard's saying they've done some work on ILI surveillance and what it should look like. So we will definitely be looking at all of those and not starting from scratch. So yes, definitely tautoko your points, Gerard. Thank you.
Nice to hear. Thank you, Christie. Our next session was meant to be chaired by Ruth, but she's had to get pulled away to do some very important work. So we're still on the session of the future of health intelligence, and I welcome Tara to the next presentation. Tara is a Principal Advisor in the Office of the Chief Science Advisory and the Evidence Research and Innovation Directorate at the Ministry of Health. Tara has a background of microbiology, public health, and the machinery of government. Was the chief advisor at the ministry and was the group manager for the strategy planning of the National Immunisation Program during COVID. You're focusing on your work at the ministry is focusing on evidence-based decision making. Very important. Looking forward to your presentation. Tara, the floor is yours.
Kia ora, thanks so much, Tim. I will share my screen. And just pop it in presentation. Great. Is that working?
Yep, looks good. Sounds good.
Stunning. Thank you so much. Kia ora tātou. Thank you so much for having me here to present on the role of evidence at the Ministry of Health, Manatū Haora. This is just a bit of background on some of the reforms that have happened at the ministry recently and the way that we're now set up to better use good quality, timely evidence. So in 2022, as part of the wider health system reforms, Ministry of Health underwent some structural changes to better reflect our role as steward of the health system. Some of this may be very well known to a lot of people, but it involved some reshuffling of functions and transfer of functions to Te Whatuora and Te Akawhaiora. And so most of the operational capacity was transferred to those agencies, and the structure of the Ministry of Health was better adjusted to sort of reflect the strengthened policy, regulation, monitoring services provided by the ministry. In addition, the role of the ministry as a source of data and high quality evidence was strengthened through the establishment of a new directorate called Te Pau Whakamarama, Evidence Research and Innovation Directorate, or ERI. So this is the vague structure of ERI. The role is to lead the ministry's analytics, research, evidence, economics, and horizon scanning functions. So the intent of that is to provide a strong evidence base for the ministry's enhanced stewardship role. The development of this directorate is really exciting, and it's come from the redesign of the ministry according to its new operating model, which has been put in place by the DG. So the ministry has 6 operating principles. 2 of them are evidence-led and future-focused, and that's where ERI plays a really critical role. We're quite a small directorate in comparison to some of the other directorate and functions at the ministry, but there's some critical functions and roles in how we work and a new way of working. So the intent of the Directorate is to provide cross-ministry support for evidence-led decision-making and guidance on support for things like working with health data, amongst a host of other functions. ERI hosts the Office of the Chief Science Advisor, which is where I sit, and OCSA serves to connect the ministry and the wider science community. We lead on the strategic use of evidence at the ministry, and we also provide evidence-informed advice to key decision makers. Other functions of ERI include the management of the National Clinical Trials Network, the Health Research Strategy, and the New Zealand Health Survey, which some of you may be familiar with. I would be remiss not to mention the Public Health Agency when you talk about evidence at the Ministry of Health in a public health forum. And obviously you've just heard from Christie, but just briefly, ERI and the Public Health Agency are pretty joined at the hip for evidence-focused work programs. So given the importance of public health focused data and evidence to the wider health system, we've collaborated on a bunch of different projects, evidence briefs, work programs, and we work really closely. We sit next door to each other. Just briefly back to the Office of the Chief Science Advisor. So it's reasonably new at the ministry. In the past, the office was a team of one, aka the Chief Science Advisor himself, Ian Town. So the COVID-19 pandemic was really a catalyst for getting the ministry to realise the importance of up-to-date, high-quality evidence and advice for policymaking. And the Chief Science Advisor played a really critical role during those pandemic years. The establishment of ERI and the expansion of the Office of the Chief Science Advisor signals the ministry's commitment to continuing on that path and embedding high-quality evidence and advice into all aspects of how it works. To date, the science advice that's been provided by the office is varied, but generally it informs priority work programs across the ministry. These are just some recent examples of some work that we've done. Generally, evidence briefs can go pretty far and wide, and we're working on getting these published as well, up on the ministry website. The other sort of key function of the Office of the Chief Science Advisor is sitting on advisory committees and steering groups. One of those key groups is the Chief Science Advisors Network, which is chaired by the Prime Minister's Chief Science Advisor. That forum serves as a really great opportunity for cross-ministry engagement on science and evidence issues, and is a really great forum for collaboration and connection. I also thought that I'd mention horizon scanning. So this is a new role that sits within ERI and works really closely with the Office of the Chief Science Advisor. And this is a Chief Advisor Horizon Scanning, Vicky Saunders. So her role is to support the ministry to identify future risks, issues, threats, opportunities for the health sector. It serves as an opportunity to be looking out into the future, seeing where we might be going and how we might address that. The function's still being fully fleshed out, and it's a new role at the ministry, but again, it's a really exciting step forward for us in the evidence space. Another part of the horizon scanning approach that's being undertaken is the development of the long-term insights briefings. So this is part of a Public Service Act, the Public Service Act 2020. So it requires all government departments to produce a long-term insights briefing at least once every 3 years. The intent of these is to contribute to future decision-making by improving public sector thinking around opportunities, challenges, and also put those opportunities into the public domain for discussion and debate. So they're independent of ministers, they're not government policy, but they're an opportunity to enhance public debate and discussion on long-term issues, and they're statutory, so that's a legal requirement. The first round of these long-term insights briefings were completed in mid-2023. The health long-term insights briefing was on precision health. It's available on the Ministry of Health website if anyone's interested in reading it. But in brief, the work done on the LTIB has set in motion a program of policy work at the ministry on genomics and precision health. Academic engagement. So this is a really exciting new program at the ministry. As part of championing evidence and research in the ministry, a program of work to better support engagement with academia has been initiated, and that's led by the Office of the Chief Science Advisor. and me. So the program focuses on strengthening collaboration and communication between academia and policy. It's been clear for quite some time that there's a lot of value in academics working more closely with government in all sorts of sectors. So we're really excited to have support from across the Ministry of Health to lead this program of work. Quite a bit of this work is based on a paper that was written by Dr. Kate Roy while she was working with the Prime Minister's Chief Science Advisor's Office. And that paper is linked down the bottom of this slide. It's available on the Prime Minister's Chief Science Advisor's website, and it provides some really great insights into how policymakers and academics can work better together. It also has some really practical suggestions and case studies, which have been really useful in building this program. So we've developed a series of outcomes sought from this program to help guide it. We have aspirations for this program of work to become embedded in the ministry's way of working. So we're building towards that sort of sustainable end state. We see this program as a two-way relationship between academia and the ministry. So we want to use the program both for supporting evidence-led decision-making, but also to provide opportunities for academics to better understand the machinery of government and the policy-making process. We want academics to have access to up-to-date strategic decision thinking. We want the communication channels to be open, frank, and free-flowing, and we want academics to be able to generate the best evidence and give the best information that they can. In addition, the program has a focus on providing specific opportunities for Māori and Pacific academics and future academics, and we're working in partnership with our Pacific Health team and our Māori Health Director at the Ministry of Health. And the intent of that is to build capacity and capability and to elevate voices at the policy and decision-making level. So we've started this as a bit of a pilot program. It's still very early stages, and we've sort of done a bit of proof of concept of the way that the ministry can benefit academics and vice versa. So in 2024 so far, we've hosted 5 academics at the ministry who've provided support on key priority projects. So from left to right, on the left there we have Professor Puna Mingtani, who is from the London School of Hygiene and Tropical Medicine. She hosted a couple of workshops for ministry staff and National Public Health Service staff on vaccine safety and H1N1. And I should also mention that MedSafe were there as well. In the middle picture there, that's Dean Rutherford, who's the DDG, Deputy Director General of the Evidence Research and Innovation Directorate. And then Ian Town, Sayali Pandaka, who's the Deputy Chief Science Advisor. And in the middle there is Rangi Mahora Reddy, who is the CEO of the Rauawa Charitable Trust. So she came and joined us at the ministry as our inaugural Aging Well Fellow. So this was a collaboration with the National Science Challenge for Aging Well. And she was the first academic fellow at the Ministry of Health and provided some really great insights on aging, gerund technology, and kind of where we're heading for the future of our populations. And on the far right there is Professor Chris Print. So Chris Print is working with us on the genomics program of work, Genomics and Precision Health, as sector liaison, which is a great step forward in sort of taking that long-term insights briefing and making it into an actual program of work. This one is a picture full of people, so I won't detail everyone, but these are 2 secondees who came and joined us at the ministry from the University of Waikato. So Dr. Jessie Whitehead and Janina Ofa-Galevsky were with us to provide insights into rural health research and evidence. And so Jessie came from the kind of health geography, GIS side of things, and Janina from the Pacific rural health perspective. Janina's a PhD student. So very exciting program. The next steps include building our international networks, working more closely with community providers, and exploring opportunities to second ministry staff into the academic sector for short-term periods to support the ministry's understanding of academia and to share and disseminate knowledge about how the ministry operates and its priorities as well. So in summary, a focus of the newly reformed ministry is to embed high quality and timely evidence into decision-making at all levels, and this is particularly facilitated by ERI and the Office of the Chief Science Advisor. We have some exciting opportunities for collaboration with academia in the future, and we're really looking forward to building the ways in which we work together to provide the best outcomes, which at the end of the day is what we're all here for. My email address is here, and the generic Office of the Chief Science Advisor email address is there as well. So if you've got any questions or you want to get in contact or you have ideas about how we could work better together, my inbox is open. And in saying that, I think I've done well for time, so I can take questions now.
Thank you very much, Tara. Yes, that was amazing. It's nice to see you acknowledge the roles of academic and policy and the decision making and the need for that good evidence to make those informed decisions. Wonderful presentation. Thank you very much. We do have 5 minutes for questions. Feel free to use the Q&A or the chat. And
see, Jared's asked, are the evidence briefs accessible online? We're working on it. The intention is to get them accessible online, and also some of them will potentially be published in academic journals as well, but not yet, unfortunately.
I have a question, Tara.
Yes.
Whilst we wait for some more questions to come through, and it's around prioritisation. How do you focus if you ignore the political influence that we often get in the ministry? How do you set sort of that priorities around what you should focus on?
We're quite lucky in the way that the Office of the Chief Science Advisor works is slightly removed from the day-to-day politics. Because it sits within that network of chief science advisors, it can be sort of more focused on holistic priorities for evidence and science that is a little more removed. And that sort of horizon scanning function is really exciting as well, because it gives us the opportunity to lift up and look beyond what is a political priority to kind of what's actually a system or a sector priority. So we're building those structures to be able to get a little bit out of the machinery of government side of things.
Nice. That's good to hear. A follow-up question.
Yes.
Yesterday we talked about bad evidence and bad science. What systems do you have in place to make sure that you're not getting influenced by bad publications and bad evidence?
Yeah, that's a great question. So we have a really, really great resource at the ministry, which is our library team, who are incredible experts in generating that those pieces of evidence for us and pulling together the literature that we need. We also the people in the Office of the Chief Science Advisor come from really varied backgrounds. So we have sociology, we have medicine, we have clinical expertise. One of our team is a part-time. She works with us part-time, and the rest of the time she's at Auckland City Hospital in the emergency department. So we're kind of trying to keep ourselves with a finger in the pie of all different types of evidence and types of research, so that we're not just kind of narrowing ourselves to one focus.
Yeah, interesting. Good to hear. Last question from me. What are your thoughts on AI?
Oh my gosh, Jeremy Tui, who's in our team, is leading the ministry program for the Office of the Chief Science Advisor on AI, and I feel like he should be here to say something. For me, because I'm a firm millennial, it's very exciting, and I'm excited by the future of it. I guess it's that demystification thing, and I can see that in the chat, the mentee thing. Some people said kind of worried or concerned or freaked out a little bit, whereas I think I'm quite optimistic about how it can help, particularly in the health sector, for those efficiencies and that taking away that administrative burden. But obviously, there's also the flip side to that. Yeah.
Yep, that's a good comment. Good and fair comment. Are there any further questions, comments? Didn't see anything coming in. Thank you very much again, Tara. It's been absolutely wonderful to hear from you. Hopefully we can hear from you next year as well, and to see how things have progressed.
Thanks so much. Thanks for having me.
Kia ora, Vince.
Kia ora.
Vince is our next speaker. We are running 2 minutes ahead of schedule. So I will slowly do your introduction, and then we'll get into your presentation if that's okay, Vince. I understand Patrick has your slides, and we'll
Yes, yeah.
yep. So you just have to prompt him when you want the slides changed. So Vince joins us from Statistics New Zealand, chief methodologist, and you've spent almost 40 years. You've spent most of your career of 40 years within Statistics New Zealand. In numerous roles, you're a member of the executive committee of the high-level group of modernisation of official statistics, which sounds very interesting. I'm looking forward to your presentation, Vince. I will give the floor to you.
Thank you, Tim. So you can already see that whatever official statisticians might be good for, zippy marketing titles is not high on the list. That's an international collaboration group that I've been part of some time. Now, Patrick, have we figured out putting up slides, or do I need
We have, and you should be seeing them now, hopefully.
Oh, thank you. Now I can. Right, great. Okay, so I'm going to talk to you today about the future of population social statistics, in particular the discussions that we're currently having and the process we're currently going through about how we might undertake the 2028 census and how we might and what that might mean for all the other social statistics that we produce. So I was just going to do this under two very broad headings, some thoughts about the current situation and some thoughts about some ways ahead, and just trying to give, obviously this is a relatively short presentation, but just trying to give a bit of a sense of what was behind some of the thinking, and stressing that at the moment, these are options that are being discussed and assessed. So Patrick, if I just say Patrick, please, and we'll go do the next slide.
We certainly can.
Thank you, Patrick. Okay, so I'm going to just sort of leap in here without giving a lot of background, assuming that there's a lot of experienced people in the audience, and observe that the way we're currently organised and the way we currently measure does leave a fair bit of unmet information need. In particular, when it comes to profiles of key communities, disabled and Māori, they're very reliant on what we call post-census surveys, which now for each of those communities are run every second year. And indeed for some other communities would like to have such collections and not really able to do that at all. So the Ministry of Pacific Peoples long-term insights briefing has a lot of commentary about data equity and the disadvantages of a one-size-fits-all data system. And it's also true that while the census has been a fantastic vehicle for measuring the population and providing indicators about those populations, some of the coverage of the topics are very thin. So topics like language usage, housing quality, even family formation, are topics of considerable complexity that at the moment we're trying to deal with one question in a self-complete environment. So we receive plenty of feedback about the need for a different approach. And acknowledging too that the measurement of population is getting complicated as well, and I could see Len's going to talk about that next. But yeah, it's true. Where immigration's a greater driver when now that and our capacity to understand where people are in regional movements is coming a bit under challenge. Patrick, please. Okay, so elements of the current situation. So it's no news to anybody. We've been struggling to get acceptable population coverage with our traditional full field enumeration census model. The 2018 census coverage was about 82-83%, very extensively reviewed. We've gone to considerable effort in 2023, but the response rate was more of the order of 89%, despite a lot of effort. We can talk about that a lot, and people may be interested in doing that. But as we look ahead, we have been looking at administrative data for about 10 years now, and have built up quite a bit of understanding. And as I've articulated here some of the more significant aspects of that. We've with both the census files we've collected, we've matched them to our admin files, and that's given us very specific information about how the two sources compare at an individual level. So we understand a lot about when people, what people put on a census form seems to be similar to how they're recorded in administrative data. We've done a lot of careful variable by variable work on both how the administrative data aligns with the statistical concept and how it tends to coverage the standard populations. And a lot of that's, if you've been looking on our website, you'll see a lot of that's available. And of course, we've, over the last couple of years, we've released a lot of experimental administrative population census files and made them available so that people can have a look how they can explore their properties. Patrick, please. Other things. So we've, in the same way that we currently take the census file and transform it into the final estimates of estimated resident population in New Zealand, we've been doing a lot of similar work. And again, if people are interested, that was published in a review journal about how you would look at taking administrative data and transforming that into the equivalent of an estimated resident population file. Some of the methods that develop traditional ways of taking of pairs and creating the population methods. I wanted to just observe that in the current way we're working, as a consequence of 2018 and 2023, that currently the administrative population data provides the base population list that underpins forming the census data set and consequently our understanding of the population. It is true that we get we do get records, census records that are not in the administrative population, and so we work to understand all that. But as things currently stand, it's the administrative list that is currently underpinning and informing what our understanding of the population. And then as we're working forward, we obviously, the IDI, which I won't expand on, I'm just going to presume that people know what that is, our integrated data infrastructure, is a rich data environment. But it's true we've got work to do, particularly in associating geography with it. Patrick, please. Okay, so when we talk about some of the directions, moving on to talk about some of the directions, this was some of the ideas that we were looking to consider. The idea was to depend more heavily and explicitly on admin data to supply population counts. The current APC file, which is just an experiment, it's almost like a raw as collected file. It hasn't been subject to all the editing and cleaning up. Has about 20 individual variables and about 5 household variables on it. It has some key ones missing for sure. But the idea was to build on that to have and to look at establishing a systems of registers for people, place, and businesses to enable us to integrate all the different types we have of data we have, so that we can get use this mechanism to try and get more detailed understanding of pictures and views of places or other lenses that we can sustain looking through the system. Now, I just want to be clear that when we're thinking about this underpins the fact that unusually this time, looking particularly at Census 2028, that the budget for the Census 2028 has been put in Stats New Zealand's baseline. So and of course it doesn't include all the money we had last time. The money we had last time included amounts for dealing with the effects of Cyclone Gabrielle and so forth. So it's a smaller amount, but the idea, the fundamental question we're trying to ask ourselves is, given all the need that is around, what is the best use of our data collection effort? So that's the notion here. So in particular, the rest of the bullet points on that slide are looking at ideas like what would you do other collection to take some of those thin ideas and find collection devices that you ask them in batteries of questions that were more useful and more extensive on language uses, just using the same example as last time. Or that you establish ways of exploring using data with communities and working with communities to figure out the concepts that they were more interested in terms of their own well-being. Patrick, please.
All these pleases, I love it.
Okay, so now we're very well aware that there are census concepts that are not well covered in admin data. So I won't go through this list. We understand that there are, and some of these, and part of the system is, well, what is a reasonable path of mitigation that we could contemplate, and how would that, what's the impact of all of that against some of the potential gains for other type of data we might collect. I'm not going to, obviously, I'm just conscious that time's starting to tick by, but so Patrick, please. So the point I'd make about this, and I don't want to suggest or glib or minimise where we have measurement difficulties, but we have done a lot of work to try and understand how those difficulties play out, and the extent to which the fact that when we're doing this integrated approach, even if there are relative weaknesses in one source, that we can borrow from strength by taking the best version of a classification variable across the data we have, or combinations of them. Location is an example where people are clearly worried because the address notifications are not all done at one time, and it's not the same as getting that in the census where you report location at one point in time. But here is what it looks like when you when the APC attempts to estimate what's called the SLA2, the low level of geography. That's the lowest level at which we produce the ERP file. So this is against the ERP as a reference population. The blue dots are the APC. The yellow dots are where the census file comes out. You'd expect the census to be a bit lower. It has a couple of conceptual exclusions. But the point is that at this SA2 level, the APC file, which is pretty unedited thing, does fairly well. Patrick, please. The ethnicity is one that I understand is of great concern to health researchers, and I do, and we acknowledge that there's at the level 4 of the ethnicity scale, which is the level of detail that a lot of agencies are not collecting it there, and there's concerns about the quality and the way it's collected in a number of data sources. And part of anything here would be working with agencies to look at how that might progress. But Patrick, please. Just looking at though, but when we look at some of the age distributions we get and here's level 2 and 3 Asian ethnicities with a relatively unedited APC file, you can see that these age populations follow the census population pretty well. Other categories are problematic, and Patrick, please. There are, and there's known problems. So the Fijian Indian, whether people are Indian or Fijian, is a well-known problem. But again, here's the level 2-3 ethnicities for the APC against the 2018 census. So, and I'm not saying that there's everything, these are all neatly resolved or solved clearly, but what I'm pointing out is that by doing this sort of analysis and monitoring how we're doing and solving these problems, we can keep track and looking at how, at the progress we're making. Patrick, please. So, yep, I just want to be clear, we're talking about using admin data. We're still looking at our concepts. We're still testing the concepts that are in the admin data against those concepts. And of course, I won't go through the detail in this slide. There are practicalities associated with data collection too, though. You can't always collect a concept that you want in a direct collection for a number of reasons. So, you know, obviously with the census, the target population, we have to have people who, we can't collect people who are away on census night, but that's within the population of the ERP. So there's but the concern about the measurement framework and the standard concepts remains. Patrick, please.
I will also give you your 5-minute warning with this next slide.
Right, okay, here we go. So tell you what, let's just move on to the next slide.
Or the one after, there we go.
Yep, admin data has some relative strengths. We can link the files from period to period, so we can understand the longitudinal movement, so we can actually understand who has moved around and where, and obviously it's more frequent. Patrick, please. So this is the main point that I wanted to make, that we are looking at this as a set of options and choices, and we are stimulating and listening to discussion about what is the need that should drive the data that we do collect. What are the priorities? So we are looking at arguments like, if we really have holes in the admin data that need more data collection to supplement the measurement of the population, then that's something we can collect data about. So there's a couple of examples given there. Obviously, migrants don't have a history of giving data in the so direct collection there. If the key objective is to enrich the content of variables, then the idea of a census attribute survey, a large-scale survey, as is done in some countries, to enable us to ask more questions and enables that content. And of course, it'll be an annual exercise, so we'll be able to rotate modules from time to time. And as I referred to before, part of this is the idea that we'd open up the possibility of using some of these resources for more targeted collections of different types, working with communities to figure out what would actually be the well-being concepts and so forth they wanted to leave. Patrick, please. Yep, this is the last slide, a process slide, because we need to. So there's been consultation. Some of you will have made submissions. Thank you. We've had some very thoughtful submissions, very thorough, with very well articulated acknowledgements and expressions of concerns. Currently, the panel's been convened, and they're working through things. So we're just at that stage of the process now. I'm going to stop because I can see I'm running my time close.
All right then.
Thank you very much, Vince, and thank you very much, Patrick.
Patrick, thanks. Yeah, after Patrick, please.
A great presentation, highlighting some very major issues that we have to overcome over the next couple of years. And we have time for a quick few questions/comments, Vince.
Yep.
We've got one in the chat around IDI being still classified as experimental. However, it's still being used for official policy making purposes. Do you have any comments on that?
Oh, so yeah, no, I don't know if that was experimental. I was referring to the administrative population census file, which is the experimental. I don't know if that's what the question is picking up on. So that is an experimental file, and to turn it into the actual population file, we'll be doing more work on it and subjecting it to some more of the disciplines of statistical production.
Right. Thank you. One last one. Your opinion on the cross-domain access to identifiable data can be a game changer for public health intel. Imagine regional, local public health services analysts having data on alcohol or vaping, tobacco sales. Do you have any comments?
Is this from existing administrative data? Do you think the question is referring to?
I guess so.
Yeah. So I suppose if the sensitivity of data, I mean, we have a lot of frameworks within IDI, including the Tikanga Paheri framework for looking at trying to ensure that researchers using the data are actually testing the impact with the communities the data's from, and so I think that sort of thought and discipline is a very proved to be a very powerful one in terms of when you're looking at questions of access to sensitive data.
Nice. Well, we're exactly right on time. Naomi, again there, Vince, thank you very much for taking the time to speak to us. It was wonderful, and I look forward to seeing how you're going to overcome all those issues. It's a daunting task, but good luck. Our next speaker is Len Cook. Len has the topic of tracking the path of the global population storm, so we might know what to do about it in New Zealand. Len was the national statistician of the United Kingdom in the early 2000s. Recent roles: President of the Institute of Public Administration, member of the New Zealand Royal Commission on Social Policy, and Vice President of the International Statistics Institute. Welcome, Len. Are you online?
Sorry about that. I think I must be getting to Joe Biden's age. Just what I intend to do, firstly, the underlying thing is, to me, we're about to enter what is the most exciting period for population studies and statistics in New Zealand in the last 50 years. We have to go back to the 60s and 70s to see such extraordinary population change on the horizon. And it's therefore really quite important that we start getting ahead of what it is. Now, just get me down to my... Right. Firstly, just in terms of the previous week, I'm actually assuming that the census that we have will be no longer. What I want to do is talk about keeping ahead of the big issues, which are understanding what I'm defining as a population storm that's coming up over the next 20 years, and I'll talk about what that is. I also think it's going to create new knowledge gaps, and they're going to involve information about place, about productivity. We can no longer just define productivity as something that's about people in the market, but we need to look at it much more in terms of community productivity. We're going to see intergenerational shifts, and our fiscal position is going to change quite dramatically, such that we're going to have to see quite a radical change in tax and welfare policies over that period. One of my, I guess, senses is that there are two things. One is, and I think I can say this with some authority, official statisticians generally don't have enough knowledge about how people that use their statistics actually use it to think about as deeply as they need to be. So they need to have really strong interactions and content. And certainly, having worked in the UK, I think the users of statistics in New Zealand are weakly organised for the oversight and scale of the coming changes to society and for shaping the statistical sources. We've got to reverse what I would call a significant dilution of statistical reporting and analysis by public institutions. We see much less now than we would have done 20 or 30 years ago when we had a planning council, population monitoring group. We've just ditched the Productivity Commission, which did some really interesting work on migration and other information. My old department now doesn't produce any published publications, and it's probably got one of the worst websites in the statistical world. So it's really hard for anyone to get access to statistics. We need to recognise that one of the ways of analysing what we're talking about is to see how an economist would. And the first comment an economist would make, or someone did when I talked to them, was that actually statistics have an asset value that is weakly revealed because the people that use it don't actually get to express what that value is, and the users don't connect with them. We need also to manage these knowledge gaps during this period of population change. And we're going to now have 20 years of instability in our backbone population measures. That 2013, 2018, 23, and 28 are all going to have the backbone measured in quite different ways. Just one wee thing where I might disagree with my friend Vince is that, in fact, we shouldn't be too optimistic about the willingness of governments to fund statistical surveys. I mean, for example, we only ever got a disability survey in New Zealand in '96 because the disability community threatened to boycott the census. We got a time use survey, despite the efforts of Margaret Shields as minister, Jenny Shipley as minister. It was only when Anne Batten came along in Winston's coalition agreement in '97 to have a time use survey, and we've only had one since. The Labour Force survey came in '84 as an opposition proposal to have it in our poverty survey. So many of our statistical surveys in New Zealand were either initiated by civil society or by the opposition political party deciding we can do it better. So and let's remember that one of the ways official statisticians have coped with that is adding a lot more questions on the census. For example, in the 70s and 80s, we learned about smoking in New Zealand, and we learned about diabetes by putting questions in the census. So I just make the point that really we have to be very wary about assuming that our mean-minded politicians of the past are going to go through some kind of transformation and be really delighted about having more statistical surveys. Just a little bit of how do we use population statistics. There are two things that are important. One is to protect the integrity of the constitutional integrity of the state. I'm not going to discuss that. But I think it's really important when you think about population statistics that there's quite a strong political element about them, because they're about the people, they're about telling us about the balance, they're about gender issues, they're about the relationship of Maori, and they're also about the position of migrants. Secondly, I'm talking really about the policy making that other people make for third parties, and those third parties are citizens. So that's really my central theme. I guess firstly, I'm going to make the point that around the world, many countries are facing unprecedented demographic change because very large and volatile migration flows are coinciding with declining fertility and increased longevity. And we're facing up to this storm now, such that what characterised our population structures and population dynamics well up to 20 years ago isn't relevant today and won't be so in 20 years' time. So we really need to understand structural changes in the population and keep ahead of them. Secondly, that Maori are typical of the indigenous populations around the world whose distinctive characteristics were previously ignored in public policy. Well, now Maori are such a significant contributor to the economic potential of the New Zealand population, as are migrant communities, that we can no longer assume that they'll be subsumed in measures that don't seriously analyse their distinct characteristics. My next point is that the variability in scale and causes of population change at both a national level and among places is making it very, very difficult to predict populations by simple demographic projections alone. What we know is that in terms, we use predictions to allocate 200 billion of infrastructure as investment around the country where we're going to place housing. The Minister of Housing himself has said that population projections are now going to be applied by 72 local authorities to determine housing plans which will create statutory obligations for them. Now, the different investment risks that you have in some areas, such as climate change management, ecosystem integrity, fiscal policy, you have a different weight to getting it wrong in the upward and positively or negatively. And so predictions are really about risk management and risk analysis as much as they are about population structure. And then I think in many ways in New Zealand, many entities get a bit confused between the two and are rather glib and think that taking our population projections is simply enough. What the consequence of that, of course, is that we can see now the Infrastructure Commission in its strategic plan says we need a population centre in New Zealand because this is a much more complex issue. The other thing is that differences in age structure and ethnic mix are quite significant locally. Natalie Jackson, 15 years ago, pointed out that in our local authorities, we are now seeing almost unique demographic structures. And that, as she pointed out, in 2/3 of local authorities in New Zealand, and you can see it in the latest statistics, we have more people leaving the workforce than joining it. In other words, the age structure is creating a flow of retirements that is not being offset by a flow of younger people coming into the workforce in those places. So it's one of the big stimulators, of course, for internal migration as well as external migration. Just a few quick statistics. You can see here fertility rates. The interesting characteristic is in the last 15 years, of course, in every age group, fertility rates have declined, which is very different than what we've experienced. We need to, just making the point, we need to really understand when we look at the different ethnic communities, their age structure and different times in which they have their first birth is also going to influence that. And our crude summary measures of fertility rates don't really help us understand that. For example, for Maori, whose age of first birth tends to be in the early 20s compared to European mothers in the early 30s, well, if you have your births in the early 30s, that population is going to reproduce itself 3 times in 100 years. If it's in your early 20s, it's 4 times. Our fertility rates don't pick up that. So there's a huge, we really need to get into fertility understanding a lot more. Here's our mortality and survivorship rates. My mother, who was born before 1920, she had a 30% chance of getting to 80, which she reached. I've got a 60% chance of getting to 80. I'm bloody close to that. My mother's grandchild has got a 75% chance of getting to 80, and her great-grandchild born a couple of months ago has got an 85% chance, or nearly 90% chance of getting to 80. So this dynamics, now all this has happened in many ways. Life expectancy has changed at age 60 since the 1970s. So until the 1970s, we really didn't see that huge shift at age 60. So again, getting our head on the combined effect of this. Now, when this is the sort of combined chart that you'll all have seen. You've probably got it as a sort of a default screen on your computers. And you can see there at 2036, around then, the population age 75 and over will exceed that 65 to 74. Our workforce a little later, the older part, 40 to 64, will be greater than 15 to 39. But all through that, the population under 15 is pretty much constant for about 90 years. So our population's going to treble, but the same number of births is about the same. And that means, firstly, if we look at this little chart I've added into it, what's the growth in the population 75 and over? And if the blue columns show the share of the population in the previous decade that was 75 and over. And on the right-hand side, you've got what the label for that. Well, what this simply means is over the next 20 years, 45% of our population growth is going to be people 75 and over. Now, we're really going to build 3-storied townhouses with steep stairwells for that population. If this is going to affect our workforce, where is the community support? Can we simply not understand the community by not having time use surveys, by not understanding the activities that people do out of the market? So I guess my point is that it ought to be our understanding of population change that drives the other information that we need. Oh, I just put my chart in just to demonstrate I can add. just a little chart. If we look at the Maori population in terms of its significance, as you'll note, as a statistician, I pointed out where we changed our measurement of ethnicity. But you know, in 1966, half the population of Maori was under 15. Now, the age distribution of the New Zealand Maori population in 2023 was pretty much the same as the European population in 1966, which was then, you could say, the starting point of the economic dynamism of the European population in New Zealand. So the prospects for the Maori population in New Zealand now are probably at the strongest they've been for a century. I'll just complete that, just a point of migration statistics, which you will all know much more than me, just to highlight on the left-hand side, the gross flows of population, the massive shifts over the last two decades, and the gross flows of people coming in and out of New Zealand. And on the right-hand side is the relative shift and volatility of the contribution of migration. But just coming back to Natalie Jackson's comment, this is taking the statistics from 2013 to 2023 census. And you can see there that the red line shows the difference in the change in population 20 to 64 years. And you can see that the huge majority of the dominance of population decline in terms of natural population change, and therefore the huge impact on migration. And I'll put in there where that we've got a change in the population 0 to 14, and a huge amount of that change, of course, is the result of migration. And just as an interesting wee example, for all of you that believe strongly in the simplicity of population projections, this is what happened to Papakura over the last 10 years. Its European population is fairly much unchanged. Its Asian population increased by 5 times to nearly the same as the European. Pacific is now half the size, and Maori is about 2/3 the size. Now, this is an extreme example of the point that Natalie was making and that I've been repeating, that we really have huge variations in what's actually happening in places around New Zealand. And of course, this creates in schools, for example, it means we've got some parts of the country where schools are having a lot of pupils, even in just around the corner from where I live, in Northland, Wellington. The new school there, I think, has got fewer pupils than it was ever designed for. And yet we know we're continually reading in the northern parts of New Zealand of schools that not only need classrooms, but just about new schools, because we're failing to adapt to the mobility within New Zealand. The total pool may be static, but in fact, where they live is changing quite dynamically. Now, what I've done here is I've just used some Treasury work and applied both the benefit costs and income levels and the implied tax take. And what you can see to people, and ended up with what I call an economic contribution index. This draws on some work by Japanese demographer Ogawa. And the red line simply points out that since 2006, the fiscal capability of the New Zealand government is falling between now and 2043 by about 1/3. And that means we either have to increase our taxes or we have to change the nature of our welfare state. You can also see I've applied the same rates to the Maori population. And what you can see there is that this is the economic potential of the Maori population because of its age structure. It's not at all affected by aging at all in the same way. And it's still got this great flow of young people coming in and joining the workforce. So we're actually seeing a Maori population whose economic capability, which it reached in the early 90s, is going to stay strong for a much longer period. Coming into your world of health, I've been struggling to get health costs, but when I look at the 2001 health analysis by age, and then I compare it with New Zealand superannuation, you can see that once you get to the early 80s, in fact, health costs are twice that of New Zealand super. So much of the work done by, for example, the Retirement Commission, suggesting that we can have a New Zealand government superannuation fund that will resolve our superannuation problems, is actually rather weak in that it forgets about the health costs. And secondly, if we're going to have a superannuation fund, why would we invest in foreign shares? Wouldn't we better investing in housing and other things that simplify the economic productivity and welfare of the younger generation and improve its taxable capability? A couple more wee slides. Oh, this is just the point I'm making, that the Maori age distribution and the non-Maori age, Maori age distribution in 23 and the non-Maori age distribution in 66 are roughly the same. The dots is the non-Maori 1966 distribution, the red dots, and the purple solid line is the Maori 23 in the share in those age groups. Just a wee comment. I did this because there's a lot of a sense that in Ogawa particularly that old people will be able to work longer and age as older generation, and that will solve part of our workforce problem. Well, we've already got there. In fact, the great advantage of New Zealand Super is that it enables people to work additionally and get a large share of it compared to a means-tested benefit for older people. So I guess the point is this is the sort of change the dynamism that you can already see in the older part of the New Zealand population. If we just now, what are some of the knowledge gaps? I think one is that knowledge about locality is increasingly important. As I said, with 200 billion of infrastructure investment, climate change responses, housing, we have got huge issues of needing to be well informed. For example, as the chief economist of the Infrastructure Commission pointed out to me, if we misallocate 50 billion of our 200 billion and put it in the wrong place, the people that get the benefit of the 150 billion are still going to have to pay for 200 billion worth. So we need to understand the cost of getting it wrong is quite high. There's a high, I've talked about the high variability of drivers of population change locally. And this is where, to me, I'm really enthusiastic about what Vince was talking about, because I think place-based statistics are going to benefit massively if only we could get our infrastructure right for the for frames for place and the ability to integrate information about place and tell us about change and improve our population estimates and understand the risk of population projections is quite significant. We need to understand the connection between market and non-market productivity. We're going to see a huge rebalancing of our welfare state. We need to understand what are we going to do with the population in terms of community activity? What will they be doing? Will we have a whole lot of people in their 70s looking after their great-grandchildren? Workforce entrance. We've got shortage in critical occupations of police, nursing, military, even truck drivers now. So the fact that we've got 60,000 babies a year on average over 70 years, I'm afraid that the opportunity cost of failing to educate and develop a child now is much higher than it was when I was born. And I think that's, again, an important element for public policy. And that means the unrealised potential from the uplift in Maori and Pacific education outcomes is critically important. And I think, for example, you're raising the point, the work that people like Jesse Whitehead are doing, we need to understand where places are delivering inequitably services which are meant to be common universally. And we're very poor at that. Why we still have huge discrepancies for Maori and Pacific and don't understand them is partly because individual government agencies are not really good at telling us where their own services are delivered inequitably. Just a wee intergenerational patterns. I made the point about the Maori age distribution. I've done work in justice. We took a huge number of young men, and the Royal Commission's just been telling us that between 60s and 80s, we chucked a whole lot of young men, particularly young women, into care, into prison. And if we didn't put them there, we put them into mental institutions. We've actually now got to the stage where the imprisonment rate of young men, Maori and non-Maori, is the same as their great-grandparents, because it's taken us 2 generations to get over what that Royal Commission has been reminding us has happened. Now, we need intergenerational studies to know that. Otherwise, Mark Mitchell will be putting the rest of the population in prison for a few more times. Here's what my conclusion. Sorry?
Lino, I wish we had some more time, but we've gone over our allocated time. If you could summarize very quickly.
Okay, this is my key point. In the end, if we're going to have effective oversight, firstly, we need to give effect to the critical importance of advisory bodies. You need to have experts sitting down in front of the people that use information. And my friends in stats ditched them all in 2014. They've got to have more, and we need them. And if the agents don't do them, the users should set them up. The position of Maori is very clear. I go into that. We need a population plan. This is proposed by the Infrastructure Commission, the Clark Commission recently, and last time we did this was 1990. We could have enriched oversight arrangements, as the UK Stats Authority has, where they both challenge governments on how they use statistics and statisticians about what they're doing. We could have a centre for reporting on population analysis. For example, the Australian Treasury and the Australian Bureau of Statistics have got a joint centre. We could encourage much more public sector and university collaboration. Do we need a centre of research excellence in population? We need to seek the voice of citizens and finally give effect to the curiosity of citizens. And my little point there, I pinched it from somewhere else. We need to put the corn out where the goats can easily get it. Anyway, thank you. Sorry for blabbing on too much.
No, there's wonderful, Len, and a great quote to finish on. Thank you very much, Naomi. We might ask you to hang around and answer any questions that come through the chat or the Q&A.
Right.
But otherwise, I would like to thank you very much for presenting with us. I will hand the chairing responsibilities over to Barry to introduce our next speaker.
Thank you, Tim. And thank you, Len. Provocative and enthusiastic as always. And it's good to have that Vince and Len together, known each other for a long time. It's interesting how your two presentations mesh so well together. So thank you to you both. I'm now delighted to introduce Dr. James Greenwell, who's going to give the next presentation. James, not only is august member of the PHONZ committee, but he's also the chief data scientist at the Ministry of Pacific Peoples, and he's honorary senior lecturer in epidemiology and biostatistics at the University of Auckland. He was previously in the Ministry of Health, but now he's moved over to the Ministry for Pacific Peoples. And James is going to give us a presentation on a novel analysis of government surveys that should challenge common policy assumptions, which is great, keeping with the theme of the conference. James.
Great. Can you hear me?
Yes.
Is my slide showing?
Yes.
Okay, great. Do you see the one with my notes or the public one? Sorry.
You've got the beautiful picture.
Ah, great. Thank you. Kia ora, everyone. Talofa lava. I'd like to thank my Data and Insights teammates who contributed to this project, including Dr. Karina Gray, who'll be chairing the next session. This presentation begins with some context about household surveys, then shifts to survey design, data collection, and dissemination of results for 6 surveys. I'll end with a set of Pacific data quality improvement recommendations based on our analysis. I'd also like to thank Stats New Zealand and Ministry of Transport who supplied data. So the Ministry for Pacific Peoples is the Crown's principal advisor on policies for Pacific peoples. Earlier this year, the Public Service Commission published a review of MPP that you can see a screenshot of on the right. The review said we needed a data and insights function that could draw together information from across government data collections and publications. It also suggested we focus more on lifting data quality. Vince Galvin mentioned our recent long-term insights briefing called Improving Pacific Data Equity, which summarizes data quality issues. So please check it out when you get a chance. This image might resonate with those of you who work with Pacific health statistics. My team spends a lot of time trying to interpret data about Pacific peoples, similar to how a public health intelligence team would work. And it can be difficult to know what you're seeing at first glance. Very often you have little guidance to go on. So thinking about that agency review I just mentioned, a challenge my teammates face once we get hold of some data is figuring out whether it's accurate. Household surveys, like Len Cook just was talking about, They're often the only source of detailed information about demographics, social attributes, outcomes, and service access the government collects for Pacific peoples. Currently, there really aren't any viable alternative data sources to replace these. Also, it can be very challenging for stakeholders to find the information they need to interpret household survey results. And this issue affects decision-making, especially if you consider, again, like we just heard, that the Pacific population is young and growing quickly. And in a well-functioning system, Pacific stats would be reported on a regular basis, allow for multivariate analysis, show a baseline and changes over time. And if numbers allowed, they'd also be reported by a Pacific ethnic group, as was the case for the COVID-19 vaccinations. So getting back to our question about understanding data quality, my team decided to begin with looking at 6 of the government's household surveys, the General Social Survey, Labor Force Survey, Household Economics Survey, Travel Survey, and Crime and Victims Survey. This is an old figure from a 2011 Stats New Zealand publication. And even though several parts are out of date, the point is that household surveys are part of a complex official statistics system produced by a range of agencies. And I'll just show this. So it's important to know that survey sample frames that we'll be looking at later are directly linked to census data. So any decisions about census changes will affect each of these surveys. Also, things like the NZ Deprivation Index and estimated resident population that we've heard also this morning, both derived from census, are used for population benchmarks and estimating coverage rates, which help us understand survey data quality. So these things are very connected. Another thing, one of the initial hurdles my team encountered was that when we wanted to find out about the surveys, there wasn't a single source of information to turn to. We started with the Stats New Zealand website, but actually the most complete source was the Reach Aotearoa website, which belongs to the private sector provider that many agencies contract to do the surveys. Now I've got a screenshot on the right to their page. So the surveys are widely used and promoted for government decision-making. If you don't know much about them, we can see the Treasury Living Standards framework on the left, the Health Status Report from Te Whatuora, recently published. In the middle, surveys also support academic research. Health surveys, for example, have been used as a public health prevalence survey and to report on unmet need for the Y2575 Māori Health Trends Report, which resulted in or contributed to health system legislation. So before I finish with context, remember that we started by questioning data accuracy. After reviewing a range of survey publications like this one on Pacific housing, our question became much more narrowly focused on finding out the statistical strength of the surveys. One of the expectations with these surveys is that stakeholders should take the results at face value. I'm sure many of you have seen these types of brief caveats. They don't really make things any easier for us to make use of published survey results about Pacific peoples. So after reviewing reported survey results, our work became focused on understanding their statistical strength. I just need to mention before we get further that any uncertainty related to surveys can be broken down into 2 broad areas. The first is uncertainty beyond the control of the surveying organization. The second, which we focus on, is uncertainty resulting from methodology decisions. There are many ways to do this, but we decided to review survey information related to these 3 domains: survey design, data collection, and dissemination. It's important to keep in mind that decisions made during the survey design phase are the first point at which data quality can be affected by underrepresentation and sampling bias. These are the set of topics we looked at related to survey design. The main thing to keep in mind with survey design is this multi-stage process depicted at the bottom, starting with selection of area units called PSUs, primary sampling units. There are around 70 to 100 dwellings per PSU all over New Zealand, followed by household selection and then selection of individuals within those households. Note that not every household in a selected PSU and not every individual in a household is eligible to take part in these surveys. In other words, there's a target population. Those PSUs are also derived from Census 2018, which therefore have limitations due to a significant census undercount and poor data quality for Pacific peoples. So here are some ways that sample design decisions can underselect Pacific peoples. Several surveys use an urban-rural selection criteria, which reflects a preference for urban dwellers, and that's fine. But really it doesn't go far enough since over 90% of Pacific peoples live in the major and large urban areas. Most surveys target those who are 15 years and older. According to Census 2018, approximately a third of the Pacific population is under 15, compared to 1 in 5 of the total population. Again, most of the surveys sample one member of a household, usually an adult, 15 plus. According to Census 2018, Pacific people in general are more likely to live in a family, multifamily, or multi-generational household, and among the least likely to live in a couple or one-person household, with Pacific people more likely to live in larger family groups. Pacific households occupy fewer dwellings relative to other groups, which can reduce the probability of selection for these surveys. According to the statutory review of Census 2023 that was just published, the inaccuracy of the address frame, which uses the postal register, resulted in a failure to meet Pacific data quality KPIs. So it's, again, it has data quality issues. And then I think I've got at the bottom, oversampling for older people. Older Pacific peoples may be undersampled if age residential care facilities are targeted. So the health survey and the crime victim survey include ARCs to get an increased sample of older people. But we know 5% of Pacific are over 64, and they're also more likely to live with other family members, not in ARCs. So those are just a few examples. There are some which I haven't included. So to understand data collection activities, we looked at this set of topics, but I'll focus on the data quality measures at the top of the slide. The thing to know about this is that most of the published measures don't say much about Pacific data quality. I don't have time to show coverage rates, but even with those, my teammates had to construct our own population denominators using the administrative population census file that Vince Galvin just mentioned to get insights about Pacific coverage and to compare those with European coverage rates. Response rates. Response rates are, for many surveys, the primary measure of data quality. The point of this slide is to show how every survey does this differently. The formula at the top is a good starting point to understand how they try to account for non-response among those selected for a survey. And that's a good starting point. Each survey actually has a different formula for response rates. Another challenge is that response rates are also measured at the household level. Therefore, they're not available by ethnicity, since individual members of a household may identify with multiple ethnicities. So what you see circled are not response rates. They're just the proportion of Pacific respondents, which is less useful to understand survey data quality. And in some cases, you get the number of respondents. Here we see only 322 for Pacific, which is why it's often impossible to do multivariate analysis for Pacific peoples. And this highlights the importance of oversampling Pacific peoples. And then here's a set of actual response rates where, in order to get insights for Pacific data quality, we have to select areas where we know large Pacific populations are, and then compare those against areas with smaller populations. not ideal. So population benchmarks. This relates to coverage rates. They allow us to weight survey responses to ensure the survey estimates match known population totals. And this is important to think about because it's another point that introduces bias to the survey results. When a population group is not included in survey benchmarks, there is no mechanism to control the relationship between the weighted survey responses that we collect through the surveys and the census population estimates. In the 3 Stats New Zealand surveys and the travel survey, Pacific peoples are not included in their set of benchmarks. Quite a few of the surveys use total population age, which does appear to account, doesn't appear to account for a Pacific age structure, which is, as we saw in the last presentation, significantly younger in terms of median age than the total population. And you can see here, I think almost all the surveys use total population age for their benchmarks. However, of all the surveys we looked at, only the health survey has a specific population benchmark for Pacific peoples. It's based on estimates of the Pacific working age population from the labor force survey. And I think it was chosen because that's a large national survey and because it used to achieve high response rates. It had a target of 90%. It's not clear if this is still a good choice since the labor force survey response rates are much, much lower than they used to be. Sorry about this slide. It's hard to read, but it's about adequate sample sizes to ensure we have enough power to detect true differences between populations and over time. As I discussed, Pacific stats benefit from oversampling even when Pacific participants are in proportion to the population. I don't have time to cover everything here in this table step by step, but basically we used census indicators like damp housing and full-time employment to estimate a required sample size, and then compared these with known unweighted survey counts from the General Social Survey and the Labor Force Survey for roughly the same period. So we estimate that for a survey sample to have enough power to detect true difference between modern Pacific peoples, you need a sample size of 2,094 for each group. And to detect true difference between Pacific and Europeans, you need a sample of 125 for each group. And we can see on that right-hand column, we have 530 Pacific people who responded to that question in that survey. And looking at the GSS one, 1,200 Māori and 6,600 Europeans. The required sample for comparing Pacific with Europeans is smaller because the difference we need to detect is large and easy to see, if you will. The difference is smaller for Māori and Pacific comparisons, so a much larger sample is needed. And you can see when we look at the labor force survey, full-time employment, that difference between Pacific and Māori is much smaller, and you need a very large sample to detect a true difference. And we didn't achieve that in the labor force survey. So these are some of the areas we looked at for dissemination. I only have time to show a couple examples of how Pacific survey results are published and used. Before I get to that, I should also point out that some of the data quality information we needed to access was only available for a fee from Stats New Zealand. This, I think, highlights an accessibility barrier because those fees add up for relatively smaller agencies like mine. So, Whakamoa dashboards. This is a good example. This is from the Māori Health Insights team at the Ministry of Health. It's not the team who manages the survey, the health survey, but we think this is a good example of how to disseminate survey data. As you can see, it includes sample error, confidence intervals are there to allow for hypothesis testing. You've got a nice context about those results, even where there are no significant results. You have time series, which is very important to gauge changes over time, and the comparator groups make a lot of sense for these indicators, which you don't often see a non-Māori, non-Pacific comparator group. This slide links back to the agency review I mentioned at the beginning. We needed to make use of what other agencies are publishing. The main thing I'm showing here is how hard it is to rely on Pacific stats that don't include some sample error. Here's an excerpt from the Health Status Report exec summary. It highlights this issue with presentation of survey results on the left and screenshot from the Health Survey Data Explorer on the right. You can see some of the important information missing in the Health Status Report. The data doesn't actually show a difference between the total population and Pacific peoples. Another thing this slide highlights is the strategy we heard about this morning from Juliet Rumball-Smith of funneling data through dashboards and data explorers without adequate context, unlike with Whakamoa dashboard. It may not work for some stakeholders like the producers of the Health Status Report. The next slide I'm just going to skip, but it's got a lot more examples from the Health Status Report of dissemination errors used with the survey results. So now just to finish up with the recommendations, these are very high level. I've got more detailed ones, so get in touch with me if you want to see those. We have 3 high level recommendations based on our findings. First, household surveys should find ways to increase the number of Pacific peoples selected and improve response rates. The next recommendation, household surveys should disseminate results and supporting information based on existing data quality frameworks. This is crucial for building trust with stakeholders. We already have existing data quality frameworks like the Principles and Protocols for Tier 1 statistics published back in 2007. Here's a table describing data quality from that document. And finally, our last recommendation, household surveys should be run as a coordinated whole-of-government program with shared data quality requirements. Here's something I came across when thinking about this issue. It's the Government Data Strategy and Roadmap, and I may have it may have some of those pathways that we can use to coordinate data outcomes, capability, and leadership for household survey improvement. Please get in touch with us if you have more questions or want to see some of the other work we're doing, looking at Census 2028 implications. We're also studying the APC that Vince Galvin mentioned, the quality of Pacific data in the APC and IDI, linkage error and linkage bias. Hopefully there's time for questions.
Thank you, James. Thanks, James, and nice presentation. And it was nice that you complimented a fellow PHONZ committee member on the quality of their work. I'm sure Peter will appreciate that. What also reinforces that when we've been talking about intelligence, how critically important the data quality is before we start doing some of the nice and fancy analyses and interpretation, the quality. So yes, we do have some time for any questions. If anybody has any, there is one. Does ethnicity recording possesses any issues for you guys? Let me just see. I assume you guys prefer to use total response ethnicity for data dissemination.
Yes. Yes, a total response is preferred. I think most agencies are doing it. The one area that probably still doesn't is the health sector. So you still see a lot of prioritized ethnicity being reported. So that's not that helpful for Pacific statistics. The other area is comparator groups. Sometimes we see comparator groups like Pacific and total population, which includes Pacific, and I had to do that in my presentation because that's what we have access to, but that's not helpful. The collection of ethnicity data, I think, is a huge issue, especially as we move to an admin data census. That's one of the things we're trying to study through our IDI research projects now, so that we can understand some of the implications for the proposed changes to the census that Vince Galvin introduced. So yeah, I hope that answers the question.
Okay, thanks, James. And once again, well done. Nice presentation. Our next speaker is Professor Richard Arnold, who is the Professor of Statistics and Data Science at Victoria University. He's also Deputy Director for the Centre of Data Science and Artificial Intelligence at the university. So welcome, Richard. And Richard's presentation is Estimating the Risk of SARS-CoV-2 Infection in New Zealand Border Arrivals. Thank you, Richard. You're on mute. Oh, Richard, you're on mute.
Oh, yeah. Hi, sorry.
That's better.
Hi, everyone, and thanks, Barry, for the invitation to speak. It's a great pleasure to be here. I'm talking about an issue which isn't current in the sense that we don't have a closed border at the moment, but of course we could one day again. And so it's nice to look back at what we did while the border was closed to assess border risk. So this is work about the risk of COVID infection among arriving passengers from various countries across the world as a tool for the Ministry of Health and the Department of Prime Minister and Cabinet to use to control border policy. So we want to assess that risk. The group of people that worked on this, some of them I'm sure are here, there was an enormous cast of characters that bumped into each other online, keen to do something during lockdown, a number of statisticians, and we ended up with a group of 6 on this particular project, myself, Rochelle Binney from Landcare, Thomas Lumley from Auckland University, Audrey Lustig from Landcare, Matt Parry from Otago, and Mike Plank from Canterbury. But a lot of other people helped form the ideas until we finally got this specific request from DPM&C to come up with a border risk model, and that's what I'm going to explain now. The data set that we had to work with was the number of arriving passengers, principally derived from arrival cards, where we learned the date of arrival and the country of origin, and also there was information on the countries that someone had visited. That data was very unreliable and in general not really captured. The case data, we have data of arrival, of course, country of origin and the arrival card origin are available 2 ways, because each case was asked where they'd come from, but that creates an inconsistency when you think about people who are non-cases having a country of origin measured in another way. So in the end, we always adopted the arrival card origin country and accepted any errors that was inevitably going to create. We needed to know what was going on at home for those people or the origin country, so we just went to the Our World in Data website and got country population size and then details on the COVID pandemic, number of new cases, estimate of the reproduction number in that country, and the proportion of tests that are positive, which is an indication of how comprehensive the testing might have been in that source country, because there was enormous variety in effort that was put into testing, and of course the results were therefore mean slightly different things from different countries where effort is higher or lower. The basic model is a simple statistical model, and there will be a few formulae in this talk. There's a simple binomial model where we model the number of cases y based on the number of arrivals n, and then we have a modeled rate of infection, that's mu, in country C in arrival period T, and everything is done here by week. Daily reporting is much too variable, and you get weekend effects which aren't real. They're just due to the delay in reporting with a spike on Mondays after the weekend. So everything is smoothed out to week. And here's an example set of data, the number of cases arriving in 2020-2021 from the UK at the New Zealand border on the left, and the number of arriving passengers on the right. Those arrivals, of course, were all being strictly controlled with the border closure, so a lot was known about their numbers and origin. The key point on this slide is the structure of the model that we use. We looked for covariates, so the model has a fixed effect of covariates, but then random effects by country. The specification there, I'll talk a little bit more about in pictures in a second, but the important thing is that countries with a background incidence rate, similar background incidence rates might not have the same risk in arrivals that actually come to the border. So I'll talk about that in a moment. It was all implemented in R. So we had to choose a model amongst the set of covariates that we had available to us. And so what we did was a simple fit a model to the data and then see how well that model predicts the following week. And the model that predicts the following week the best, that's the one we chose. So we investigated this various set of covariates that we had available. So again, things like reproduction number, the incidence, the proportion of tests that are positive, and try to minimize the prediction error. So the one step ahead prediction error, how well does it predict the real data using data only fitted up to the previous week? And that's what this MAD is, the mean absolute deviation. Final model we chose actually only retained in-country incidence. And there are a couple of reasons for that. The biggest reason is that the data on those other factors was simply too unreliable and have very weak predictive power. Only really incidence in the source country was predictive. And we found that current incidence in the week immediately before the arrival was to take place and the 2 previous weeks, they were the only sufficiently powerful predictors. So that makes things quite simple. The only covariates in this model are incidence in the source country plus this random effect structure. And I'll talk a little bit more about that in the slides just to come. In order to forecast, we need to take the incidence, this one covariate, and predict it into the future. So of course, we don't know what the incidence will be in the future. So what we do is a log linear extrapolation, and we'll see pictures of that in a second. And we're really only looking at a horizon of 3 weeks. I'll show you longer periods than that, longer forecast periods than 3 weeks, but we're really only looking at a 3-week forecast, and probably really in practical cases only 2. The arrivals, of course, we don't really know what the arrivals are going to be, but in a strictly controlled setting, we may know from bookings in MIQ what the expected origins are from the various countries. So we'll be able to predict that. And we also need to forecast the random effects, and I'll explain that when we finally get to some pictures. So here is an example. We'll continue to use the UK as an example. And there are the arrivals in 2020, starting in June, going down to August in 2021. And then this forecast period in grey, I'll just forecast forward a number of weeks. And all we do is take the average of the last 3 data points and forecast that onwards. The incidence in the UK, so not incidence amongst arriving passengers, but incidence in the UK of COVID obviously varies over time, and we have the red curve up to the grey area, that's what we know, and then we forecast that forward. And because that was on an increasing trend in the last few weeks, it gets a further increasing trend into the grey area. But it's only really the first quarter of that grey area that we take in any way seriously. So a huge spike in incidence upwards towards the end isn't something that we're going to take seriously for forecasting purposes. These are the rates of infection amongst actually arriving passengers. So to distinguish that, this was incidence, the rate of infection amongst people in the UK. This is historical incidence of COVID amongst arriving passengers. And of course, they're 2 different things. And pulling those apart is the job of the random effect we're about to get to. This is a simple fit. So the heavy red curve there, and that's the prediction of the rate, amongst arriving cases that we expect. And the increase there is being driven in the forecast area, the grey area, that's being driven by the fact that incidence in the UK was increasing, was forecast to be increasing in that period. We can fit confidence intervals here. The numbers are small, so we get massively wide confidence intervals. But for practical purposes, we were reporting only the lower and upper quartile, so a factor of 50% central confidence interval, just in order not to give results that were too unusable for certain countries. There's the the difference between the confidence interval and the prediction interval. The confidence interval is our guess at the mean rate of infection, but the prediction interval includes the variability that we actually expect to see, the binomial variability that we expect to see. The green line here is the one step ahead forecast, and so that's what we use for model selection. So how well does the green line match the blue data? The green line in each case is the forecast into the following week. And it looks a little bit like just simply like a 1 week lag of the data. So it goes down and up according to what the data looked like just prior, but it is heavily moderated by the incidence in the source country at the time. Okay, the random effects. I haven't really talked about these yet, but this is a way of distinguishing countries which might have higher or lower incidence amongst their arriving passengers than they do in the source country. So here, if you look, there's a solid blue line that runs across. That's the country level random effect. We only use the previous 30 weeks to fit this. And you can see that it's negative if you look on the scale. 0 is the dotted line towards the top. And this one is negative. This says that amongst UK arrivals, the risk of infection, they are less risky than a random person in the UK back at home. So that means that for whatever reason, that the people who are selected and who choose to come to New Zealand and get into MIQ are less risky than people, randomly selected people from the country back home. So that's that constant random effect. We also allow for a random time varying wandering, that's the red, which shows how that overall 30-week effect does wander up and down, and that's there's an autoregressive effect there. Into the forecast period, the blue line, of course, carries on. The red line is forced forced onto the blue line during the forecast period because we don't know what the random walk is going to be. So that's the two component random effects. So it's maybe a little hard to see on your screens, but these are the forecasts for various countries. There's India at top left, UK that we've already seen, the US, Australia, Pakistan, and Afghanistan. These are countries with relatively high numbers of arrivals. So we do this per country and forecast forward the expected rates, the expected counts as well, based on our expectation of the number of arrivals. The random effects look like this. So the middle of the top row is the UK, and that's the diagram you've already seen. To the right of it, the US, that's also got a negative random effect. So again, arrivals from the US are less risky than people in the country that they're coming from. If you look on the left, at the top, the random effect is positive for India. And that suggests that people arriving from India are more risky. They have a higher rate of infection than do people at home in India. And there's a slight risk there that, of course, if the testing is not comprehensive in India, in other words, the incidence rate is an underestimate, that can cause this random effect. I think I've said all of this. So the country level random effect absorbs the difference between how travellers differ from the general population, as well as some in-transit risk. We thought hard about how to model the fact that people getting on planes from different countries were sharing infection potentially. And we have the time-dependent random walk allows for time dependence in the policy change or changes in practice and case ascertainment, and even emergence of new variants. Some countries we have basically no information at all, so we either delete the random effect at all or set it to 0, or we just use the model, effectively then using the model from other countries to use to predict the rates for countries where we have very, very little data, or perhaps none at all. And that led to then a week-by-week risk map, so saying we could classify the countries as being higher or lower risk. And then we handed all this over to the Ministry of Health, who used it as one of the things that they used to consider how to determine which the policy settings for specific countries. And this is a simple approach that could be implemented next time when this happens. And we've got a paper coming out detailing basically everything that I just said. Okay, that's it from me. Thanks very much.
Thanks, Richard. Great presentation. And just shows you what you can do with a whole bunch of statisticians together, letting them loose on data, and how it actually leads to some positive work for the people in control in the ministry and the ministers. So thanks very much for that. Any questions for Richard? Any comments for Richard?
All feels a little while ago now, in fact, that blundering around in Zoom space trying to find people to work on something and not meeting in person ever.
So could it be applied to other things rather than just COVID?
Absolutely. So it's a simple process where you say, I know what's going on, the incidence rate of whatever this condition is in all these different countries. You calibrate the model on the data that you've seen, and then use it to bring it forwards. And that's the key point, actually, is that the model benefits from knowing data about actual arrivals. So we don't just treat every country the same. We say, well, what have we learned in the past from arrivals we've seen from those countries? And then we end up with this differential random effect that absorbs whatever the difference. And we don't need to attribute that difference to any particular cause. We don't need to model effectiveness of the testing regime explicitly. We don't need to model transit risk explicitly. All we do is say, typically, this is how you compare as an arrival to your home country, the incidence rates that's reported, if not actual incidence rates.
That's great. So it means we won't have to employ statisticians to redo the model.
Indeed.
Hey, well, thanks very much, Richard. Really appreciate your time and also the presentation. It's my pleasure now to introduce Dr. Osman Mansoor, who's actually a public health medicine specialist. Anyone that knows Aussie will know that he's got wide experience in many areas. He's worked for the Public Health Commission, and a few people might remember that. And he's worked for the Ministry of Health and WHO, but he's currently now Medical Officer of Health in Tairāwhiti, which is part of the National Public Health System. And he's going to give us a presentation on a Substack of Tairāwhiti district data. Thank you, Oz.
Yura, can you hear me and see me?
Yes.
Excellent. Just put it on presentation mode. Yeah, kia ora, and thank you for letting me share a few tidbits from my district. So the presentation is really about the Substack, and it's really all material from my Substack, including the introduction that I put there, which I started the Substack a year ago, saying a bit about myself and what I want to do. I'm not going to read it out. I'll let you read that for yourselves. But then also about the fact that data is always suspect, starting with my birth date. And I think we've had a lot of discussions here about suspect data and so on. And a little bit about our district, which is the smallest district in New Zealand. And interestingly, from an epidemiological perspective, has a nice number of population, which is 1% of the national population, roughly, and about 50,000, which makes working out rates per 100,000 or comparing national rates quite useful. So this started with COVID. And we were the only New Zealand district with no local spread of COVID before Omicron came January. The first case was reported 28th of January. And I was starting to do these daily updates of the cases. And these are some of the earlier ones, trying to just showing what's gone. And looking at the trend line that emerged quite early, that it seemed to continue with the cases really doubling every 4 days. And by the 19th of March, I was just showing some other ways of looking at the data in terms of who is in the cases, but also you can see quite clearly that trend line. And if the graphs are getting very complicated and crowded, and from that, we moved to something a little bit simpler, moved away from what was previously a logistical line to a linear line. So then what became a straight line becomes a curve with the curves going down. And I was doing this really pretty much most days for a while, and while COVID was interested, and decided to share it more publicly as notifications were mostly from the public. And going from that graph of COVID, this was the first one I did when I started in July last year. This is showing the cases reported. I would say cases here, but actually it's notifications, and I think we'll come back to that mainly because these are just the cases that have been notified. And basically after the initial peak were pretty much all mostly self-notified. And with the graph, I would put a little comment in that box, which I would update as the things observed. One of the things you can see in that graph there is a little gap between the 14th and 19th of February, when during the cyclone, all systems were down and we stopped reporting. You can also see that we have the Rhythms and Vines, a big annual festival to mark the new year, and we had a burst of that for that year and last year. I'm sure we'll have another one this year. And moving from that daily graph, be it from there to, because I'm doing a weekly update, moving to the daily graph of the COVID chart, showing something as well in this one, which is how many times people hadn't been notified. Because I think the most we've had is one person who's had reported COVID 7 times. But as you can see, it's usually about a third of the cases are first-time infections, and then a second and third infections. And then added onto this, the number of hospitalizations. And I'll come back to that later with the COVID hospitalizations. But really, that was a starting impetus for this, doing this Substack, but then also writing about other district notifications, usually writing about what's coming in, what's been reported in that week, but also using the end of the year, end of the quarter to compare how we're doing with notifications. And I just used to highlight a couple of things. Was there with the leptospira, we were very concerned, and I think Hawke's Bay had quite a large increase in leptospirosis with the flood. We saw a small increase, but that was on terms of a rising trend. But that trend hasn't continued into 2024, which you can see in the first 2 halves. You only had 3 cases for this year. The other interesting thing is that we saw, in terms of Yersinia has become, Campylobacter has always been the most common one before we had COVID, which is now on a different 2 orders of magnitude greater. But Yersinia has become has become increasingly common, less so in 23 than 2022. It seems to have peaked a little bit, but we have continuing to have higher rates of Yersinia than any other enteric infection, which is unusual. And I think we're kind of struggling to understand why that is, because we don't find any particular case. And I think talking about these things in the Substack to share what's going on in the district. One of the interesting things with COVID is we saw the reduction in viral infections leading to reductions in secondary bacterial infections, particularly meningococcal and invasive pneumococcal. And we can see that very clearly for our Tairāwhiti meningococcal notifications, but not so much for the invasive pneumococcal disease. I don't know why, because generally both of them have been dropped in there, but I think also reflects the fact that we got very small numbers and small number variation. So some of the other data presenting, as I said, we've got 1% of the population. So it's actually quite, by just comparing the numbers locally and nationally, we're effectively comparing incidents. And we had a recent dengue case after a long gap, partly from the pandemic, but also, again, small numbers, more or less in line with what we're seeing in nationally. And similarly for the TB notifications. And interesting to see here, we're starting to get, traditionally we have very high TB district going back, and increasingly now most of our cases are from overseas born people. So again, each time these were all prompted by a case of TB or a case of there, and to update what's been going on in the district. Rheumatic fever is considering, and here I just ask you to compare the axis here, because we should be at 1%, so our high should be 2 to be comparable with November. We're at our highs at 10, which is 5 times, but also our pattern looks somewhat different. Quite a drop nationally in 21 and 22, possibly related to the pandemic, whereas we seem to have gone up in 21 and 22, but had a drop in 2019 and 2020. The other thing was just trying to present different ways of showing the data, looking at the change in data by year and by month. I'm not sure this was the best way, but that's what Excel offered me at the time. And just one example with that increase I mentioned with Yersinia that we've seen, which seems to be pretty much year round, but also particularly around the January holidays. So as well as talking about disease, I've also tried to talk about other things. One of the things in the recent ones was talking about the risk we are immunization and our priority really to catch up primary and primary school, well, all school children and early childhood center. And this graph is really showing 1- coverage, or, percent of children who are not protected by the type of center in our district and the number of children to show the kind of work that would be needed if we wanted to stop the impending measles epidemic. So I've also got going back in details, just looking at COVID hospitalizations, doing some reviews, looking at how does the cases compare with the hospitalizations. And it's interesting if you look at the inset there, the continuing decline of cases, how much of that is due to declining notification as opposed to declining trend is unclear, but we know that the amount of cases being notified is continuing to decline. And yet the hospitalizations after that, the first year seem to be relatively high and ongoing. And because the cases are going down and the hospital is relatively fat, we've got increasing rate of hospitalization per number of cases. And I think notice generally have more Maori hospitalized per case than non-Maori, maybe because there's more underreporting in Maori, maybe because they increased risk of hospitalization, maybe both. And this is just something from the cause. We have the one hospital that's covering the whole district, and they're still giving us the case whether they've been admitted because of COVID and something else, or they were admitted for something else entirely and just happened to be positive for COVID, including some cases who got infected in hospital. And again, as you see, the importance, we seem to have this trend over time. I think we need some more. I'm not quite sure what intelligence to draw out of that pattern, but I thought it was interesting change over time. And then looking at it even more globally, I've been reflecting about, I think, the remarkable experience to have been through a pandemic with really no impact on our population and compared with the other countries. When I did the graph, when I got this data from Our World in Data to put on the Substack, I had not long been from my sabbatical in Mauritius. And it was interesting in Mauritius because they also had a very effective initial policy of eliminating it, but then they had some failures and it ripped, and you can see that there. And there was also at that time the Lancet study looking at the looking at the impact of the pandemic on global life expectancy, and New Zealand being one of only 32 countries and territories where it didn't decline, where it has. And I think it's another remarkable thing. I just updated this graph recently because I was also interested to look at the impact of Hong Kong. So I think they're also similar to New Zealand in keeping it out, but the difference is when it came in is that they didn't have the highly vaccinated older population. And again, this one was the latest one from World, still showing that we're barely above, cumulative net. We haven't seen any compensatory deaths really in terms of the cumulative excess mortality a couple of years into the pandemic circulating locally. Looking in more detail, I'm using NZ stats to get our local thing. It's slightly complicating because the national mortality data on the left is for the calendar year. And when I did this, I only had it for calendar year ending June, so not quite matching. But the point of the first graph was to show that even though mortality was declining, the number of deaths will continue to increase because of our population growth. And here showing it on Tairāwhiti, it'll be interesting to see here, look at the range of mortality nationally drops from above 0.75 down to 0.65%, whereas in Tairāwhiti it's going up to 0.9% and only down to 0.75%, reflecting the fact that we've got a very Maori and more deprived population that have higher mortality. But again, as with there, you can see the trend in mortality has been declining over time. At just the bottom, just the actual number of deaths over this period, and then to calculate the excess deaths. Bloomberg had published an analysis showing that for New Zealand, there was something like 385 deaths, negative excess deaths, deaths that we didn't have because of the pandemic, which was there, which would equate to about 4 for our district at 1%. And doing my calculations, say, well, the excess deaths depends very much on what your baseline is. And even just if we just use the baseline as the average of deaths, whether we include 2016 or not, in other words, whether we do 2016 to 19 as a 5-year or just a 4-year baseline, it makes a difference because we had a low number of deaths. So if you're just looking at the average number and compare it for 22, 23, we either have 27 excess deaths or 45, depending on what we choose the baseline is. But then if I just do a simple linear trend, here use with Excel, and here the blue's the actual graphs. You can see with the red, the total deaths, I end up with 417 excess deaths avoided, and I put that there, just showing there, and that was just to show how different methods can do it. But I think whichever way we do it, it still remains a remarkable and I think underappreciated how well we sailed through this pandemic despite all of the problems. Finally, just to show the kind of uptake in there. There is a slight issue locally in that our servers block the Substack email, so that I actually have to send it to my subscribers locally. But I also share it on LinkedIn, and you can see some posts there. And these subscribers, not a huge volume. The total subscribers is just over 60, and is fairly slowly growing to flat. And just conclude with really some thoughts to try and get some feedback, because it's a really good opportunity. I've been doing this for years and experiment as basically changing the workflow as what I was doing to try and do it sustained and to try and have a broader issues, which in some senses I've done very limited. And Substack was, at the time I was introduced, as people going out of Twitter, and seemed to be good sources of information there. So I thought, why not do my own? And it was free. And really to try and communicate that information there. And I think there's a typo in building trust, which it may or may not be deliberate, because I think it's a real trouble. But I think part of my underlying thing is about how do we address the problem in trust. And there's always the issue with notifications about acknowledging the notifiers, and not just notifiers, there's a whole lot of systems involved here in case we get the hospital staff informing about the hospitalized cases now. And in terms of notification, it has been traditionally been health professionals, but with COVID, they are really essentially all, or minus 1 or 2, provided by the public now. And would be interesting to your thoughts about the use of the Substack as a way of sharing data and engaging public in there, but also most fundamentally building trust as to a local source of information. So thank you for that.
Thank you, Oz. Great presentation and an introduction, certainly for me, to another product that just gets the message out that you're trying to do. So well done. Any questions? Question: how do you report on NCD from Tim?
Yeah, I've always kind of had a bit of about what I report on, because as I said, it started off with the COVID data, with sharing that, because that was obviously very hot at one time. And then I added with the other notification data. Haven't really, I think I have talked about health risk and NCD data, and I think there's a whole issue of data, but generally I don't have access to those data as easy as I have. I have access, I use Episerve. One of the things I didn't comment on is about data quality and issues within Episerve and so on, because the systems are moving on. But yes, I'm interested. I think for me, the idea is really about engaging the community, and I think including NCTs. And I have written about health risks, and particularly the 5 risks that have been focused in the government in my last update on health risks. But I haven't specifically, and obviously in terms of disease burden, in terms of risks, they're obviously far the biggest burden for our community.
Good. Thanks very much. And if anybody has any comments, Oz did take the step of asking for your thoughts. So I suggest if you have any, send them either through the chat, we can give them to him, or send them directly to Oz. It's now time for a break. I'd like to thank, on behalf of the PHONZ committee, the chairs, but also the speakers for excellent presentations this morning. And once again, thank you, Patrick, for your diligent work in the engine room. We'll now take a break for a quarter of an hour and start again at 12:30. Well, not quite quarter of an hour, whatever it is, to 12:30. And Karina will take over the chairing for this afternoon. So once again, thank you, everyone, and enjoy whatever it is that you're going to have for the next 10 minutes.
Tēnā koutou katoa, and welcome to the final session for day 2. My name is Karina, and I'm the Deputy Secretary of Policy and Insights at the Ministry for Pacific Peoples and also the Treasurer of PHONZ. It's my pleasure to be chairing this next session, which is on the implications of AI for health intelligence. And our next speaker is Professor Alistair Knott, on the uses and risks of generative AI in healthcare. Welcome, Alistair.
Cheers. Just sharing my screen. So can people see that?
We can, but it's quite a small window. Could you go full screen? There we go.
So yeah, that's the topic for me today. And it was interesting to see that word cloud in the coffee break popping up, and I'll pick up on some of the concepts that people put in that word cloud in what I'm talking about. So I'll sort of be introducing this general area of AI in healthcare, I suppose, and there'll be other people talking on similar topics. So a lot of what I talk about will come, or at least be my own sort of perspective on an interesting report that came out earlier this year. I'm not sure if people in this group will have seen this. Maybe some of you were part of writing it. So this came from the Prime Minister's Chief Science Advisor, and it was about AI in healthcare in New Zealand. So I'll be drawing on some things in there. So that report had 5 authors who were mostly from the Chief Science Advisor's office, but also including Ian Town from the Ministry of Health. Then there was an advisory panel that I was on, and then quite a large group of people who we consulted to ask for their opinions about this. Some of them were most of them were in New Zealand, but they were also from various other places in the world, the US and Australia in particular. So I'll try and sort of summarize some of the recommendations or findings, and this might be the thing, I suppose, almost that caused the report to be written. So this was a report that was ordered by Chris Hipkins when he was Prime Minister, and the fundamental issue that they were thinking about when they commissioned this work is that there's a shortage of healthcare professionals, not just in New Zealand, but everywhere, and that's not going to go down. And so it's not going to be possible for us to go and recruit healthcare professionals for other places, because there's going to be huge competition for healthcare professionals, and the number of people who are being trained probably won't meet demand. Demand is growing again in New Zealand and elsewhere too. And that's partly because populations are aging, but also partly because new medicine can be done these days. We're discovering new things and new treatments, and that means the amount of work that can be done is growing as well. And those two things push in opposite directions. And if there's a static supply of human professionals, then the question of how we meet the demand, is a really difficult one. And maybe increased automation, including applied statistics and AI, may well be part of the answer. But the question is, how can we do that safely, I suppose? So in the report that we wrote, we started off with this interesting kind of aspirational vision about what healthcare might look like for a GP, for instance, in 2035. And I'll just kind of give you some extracts from that to illustrate some of the possible technologies that we're sort of like optimistically imagining might be available. So this is very grounded in particular kind of case examples. So there's someone called Jade, who's a GP in Newmarket, and she's part of a team practice at the heart of some local community. And in her practice, so most patients arrive already having done some preliminary consultation with some personalized AI healthcare module that operates kind of like doing home healthcare or something. So people, for instance, can have data gathered about their case on a smartwatch. So when some particular patient, Hammy, arrives, Jade already knows that certain issues have been arising because she has a personal AI that is that's making her aware of his situation, and the AI actually also is in interaction with the patient, Hammy, and suggested he go to the GP for various reasons. So it's like there's a conversation here. The AI is having a conversation with Hammy and with the doctor. extremely aspirational, but the point was to sort of, I'm focusing here on the generative models, the new models where, there may be things that can be done, but we might need to be cautious. So the AI listens into the consultation between Amy and Jade, and then afterwards offers a range of possible treatments for Jade to consider. So a range of possible diagnoses that come from the AI sort of overhearing the conversation between Jade and Amy, and therefore putting things out there that Jade may possibly decide to take up. And this is another interesting one. I'm just taking extracts from this long multi-page sort of aspirational kind of scenario. So at the end of the day, Jade asks the AI to run through the day and check all the notes that she's written and the conversations she's had and alert her to anomalies or omissions. That's the kind of general purpose task which language models, generative tools seem able to do, at least approximately in some cases. And so the AI can perform this sort of oversight function on the GP's work, and then also can sort of do things kind of in anticipation of tomorrow. So she asks the AI whether she should come in early to prepare for anything in case there's anything out of the ordinary. And again, the AI can advise her on those sorts of things. So that all seems rather science fiction, but nonetheless, those are the sorts of tools that people are talking about in AI these days. So the question is, how can you safely do anything like that? Are we ready to do that? What would be involved? There's a huge number of questions that relate to due diligence, basically, around how we go about thinking whether even that is halfway feasible. And the word safety came up in that word cloud that Patrick put up just now. So our report outlines several principles that we can kind of use to guide us in this area, and the principles probably won't be any surprise to this group, but nonetheless, here are some of them. So one of them is that, okay, so there may be some automation, but that automation shouldn't get in the way of there being a kind of constant human element of care in any patient relationship. So automation shouldn't get in the way of that. And any automation, any AI system should, the word is tackle inequality. So there is inequality, and the idea is that the AI systems should be able to, in some sense, address that, identify it, and work to reduce it, rather than just persist the current inequalities or something like that, let alone make things worse. So that's quite a big goal as well. And then there are certain principles which are specific to us being in New Zealand, in particular our obligations under the treaty. So what I'm going to focus on is something else, which came up in Mansoor's talk at the very end. That was like his sort of punchline. So this connects quite well with what he was saying. And also it came up at the very center of that word cloud that Patrick was talking about, the word trust or distrust, actually. If you're going to do this sort of thing, you need to create public trust or get public trust in some way around the systems that are being used. And in the report, and to me, this was the most interesting kind of conclusion that we reached that we didn't sort of arrive with beforehand. There were actually discussions that trustworthiness for AI systems in this kind of domain, this kind of public sector domain, comes a lot from transparency. Transparency is an extremely important way. It's like an instrument through which we can gain trust, partly trust of professionals who are going to be using the technology, and partly trust of citizens who are subject to the technology in some way. So trust, we discussed trust around several things, but I'll focus on two things in this short talk today. One of them is about how well systems work, basically. We'd like there to be transparency about, does it work? Is it good? How good is it? Is it better than a person or not? How, what's the percentage score? Can you give it a score out of 10 or something like that? So that's one central thing which will go to creating public trust, because both professionals and citizens would want to know about that, because that's the sort of acid test, I suppose, for any AI system. Is it doing a useful job? Is it working well? And the second thing comes from transparency about data. So we're talking about AI systems, which are all machine learning systems these days. Those systems are trained on data. The data is about people, people's medical conditions, people's healthcare outcomes, and we need transparency about that data. Was it obtained through legitimate sources? What involvement did people have in allowing the use of this data, their data, for these kinds of tasks, and those kind of questions. So I'll cover. That's basically my my outline for what I'll be talking about today. So one thing I want to say, and again, the report talks about this, is that how you achieve these kinds of transparency. It's useful to distinguish two different sorts of AI in order to address how transparency in these areas of evaluation and training data, how those things work. So I'll start off by introducing the two types. So we call them generative AI and predictive AI. These are very rough labels, but for policy, we thought this is a useful distinction to make. So whether the distinction between these two types of AI can be so neatly made at the level of the technical methods underneath is another question. But in terms of kind of the way that they're used, we felt this was a useful distinction. So I'll sort of lay it out before you. So a predictive model is something that learns from training data to map A onto B from training examples where A and B are both known. And so you have examples where the relationship is known, and you learn from those examples, you know, in such a way as to generalize to new examples. So in the new examples, you're given a new A that you haven't seen before, and you have to predict B. And so you can imagine that happening. But the idea is this is a rather kind of ramified scenario where you know what the input is, it's like this, and you know what the output is, it's like this, and you're just learning the mapping between inputs and outputs. So let me give some examples. So these kind of examples came up in our future scenario as well, but I didn't focus on them because I was focusing on the generative stuff. Here's an example of a predictive model.
How are you?
Okay.
I have a weird question.
Is there someone who's got their mic on? Just checking. It's not a question, right?
That wasn't a question. That's been dealt with. Carry on.
Okay, so anyway, imagine you have a system that takes images of people's skin lesions, and then there's some human expert that's able to say, yes, that's cancerous, yes, that's cancerous, no, that's not cancerous, or this is this type of cancer, and so on. So the A in this case is the picture of the skin lesion. The B is that's being predicted is the cancer outcome, whether it is a cancer or not, and if it is a cancer, what sort it is. So it's a rather clear kind of like constrained situation that's used in a particular diagnostic context. Here's another one. This goes to kind of public health, I suppose. So a system that predicts the length of a hospital stay for a patient from data about that patient when they came in, what they present with, other facts about the case. So again, you can imagine getting training data because you can actually record how long individual people stayed, and then record the data that they came in with, and then you can learn a mapping that extends to new cases. That helps you schedule beds in a hospital, for instance. So systems like that have been around for a long time. And one interesting thing about predictive AI models is that it's a term that extends to new AI systems, for instance, deep networks or decision trees or support vector machines. But it also applies to sort of statistical tools that have been around forever, like linear regression or regression or something like that. And so it usefully extends to those two sorts of things that can both be understood as learning to map A onto B from a set of training examples. So that's kind of well-known stuff. A generative model, on the other hand, is something that's characterized by its ability to produce a huge range of very realistic content. So a text model, like a large language model like GPT, can produce realistic texts that seem to follow on naturally from the prompts that you provide. So they can do things like answer questions or summarize documents or translate the sorts of text processing that people do in ordinary, in many different tasks. And they do that by being trained on vast amounts of similar content. So they essentially learn to produce content that is from the same domain as the content they train from. So it might be text, or it might be images. And so you have models like Midjourney that are trained on vast numbers of images, and then can produce images in response to a prompt again. And when I say realistic there, I mean they're images that might look like they're drawings or photos. So they're quite convincing in that sense. So in this aspirational scenario that I started off with, I had various situations where the generative AI model was the thing that was doing the AI in that scenario. So the AI suggested something to Hemi. That's something which involves conversation. So the AI has been monitoring Hemi's health data on their smartwatch, and then starts a conversation or engages in a conversation with the patient. The AI listens in to a consultation. So they're listening to a dialogue and processing the dialogue, and then at a certain point, jumping in that dialogue and making suggestions, in this case to the GP. And here's another one. The AI has been watching Jade's schedule, is looking at Jade's case notes, and is reviewing the schedule, which is another type of text, and then is able to make suggestions based on the way the schedule is. So generative AI tools and those kind of aspirational applications are all completely new. So they're very different to this, because this stuff has been around for a long time, even though AI models are getting better at making predictions in some cases. That the basic pattern has been around for a while, whereas these generative tools that are able to work in arbitrary textual scenarios, in arbitrary content scenarios, and sort of apparently do useful work, they're very new. So there's a couple of big differences between predictive and generative AI, and I'll spell out one of them and then the other one later. So here's the way I'll sort of state the first difference. So predictive AI systems, like that cancer detection thing or the hospital bed prediction thing, are trained to do one task and then deployed to do exactly that same task. So for instance, that cancer detection tool is trained on exactly that task that it's used for. And the same with the hospital bed occupancy system. But that's not true of generative AI models. So just a tiny bit of detail about those. So they're trained to do one thing, they're optimized to do one thing, and then used to do something quite different. So they're deployed for something different than the thing that they were trained on. So all of these tools, I'm simplifying a little bit here, they're trained to predict the next word in a text. So they're trained basically to sort of like to understand what texts look like, coherent text. Sometimes they predict a word that's in the middle. Sometimes they predict something about the next whole sentence or paragraph. But essentially, they're learning what coherent texts look like. And it's because of that that they're able to generate such realistic looking texts in this case. But they're not used to predict the next word. They're used, the tasks that they're used for are defined much more abstractly. So for instance, it might be, listening to a conversation and then jumping in, or it might be reviewing a schedule of a GP's work for the next day, or it might be summarizing patient notes and reporting them or something like that. So those tasks are just differently defined from the task that a language model is trained on, which is literally to fill in the blanks at the lowest possible level of granularity. So the reason they can do lots of tasks, they're reasonably good. The trained model, when it's already ready trained and sort of shipped out to users like us, has been trained on so many texts, and it's got such powerful generalization abilities that you can deploy it on almost anything, and it's probably seen something a bit like that in its training set. Or if it hasn't seen exactly that, it can generalize away from the things it has seen in order to make a reasonably good fist at whatever you ask it to do. But it wasn't trained to do the thing that you're getting it to do, for instance, in the healthcare domain. And that means that they're also able to mess up spectacularly, and that's where hallucinations come from and things like that. Sometimes it just gets things badly wrong because it's not like this situation with the predictive model where it's being deployed on exactly what it was trained and optimized for. So if you train it and optimize it and work out that on your unseen examples, it does like 99% of cases, you can be reasonably confident that it will be that, that similar accuracy in its deployment in the world, provided you keep your data fresh. But that guarantee is much harder to provide in this case.
Alistair, I'm sorry to cut across you, but you're running over time, so I wonder if you might
Oh,
summarize.
Yeah, okay. So I'll summarize just by finishing on this point. So we know very well how to evaluate predictive AI models. You train them on a set of examples and you hold out some of those examples from training and see how well the trained system does on those. So what we need for a generative AI model is a good way of evaluating it, especially in a safety critical case like healthcare. So the acid test is something like, does the system work as well as a person in the given domain? And that requires just a lot of testing with expert human judges. And I guess I'll just finish on this point. So we also know very well how to evaluate the bias on predictive models or the fairness of predictive models. Does it make different sorts of errors on different groups of the population? But we don't know anything like as much about how to evaluate the bias of a language model or a generative model in general. And so we've got a new evaluation challenge. And I guess I'll just finish by noting that yeah, we need to work hard on this open research question of how to evaluate generative AI models. And I'll finish there.
That was an excellent presentation. Thank you so much for that, Alistair. I just wonder if you have any questions, what we might do is just ask you to put that in the chat or the question and answer function. And then perhaps, Alistair, if you stay online and answer the questions in the chat, that would be really awesome. Thank you. And now we'll move.
I have something else to go to at 1. So in the next few minutes, I can.
So you have 7 minutes to ask questions, everybody. Thank you so much. Okay, we'll move across to the next talk, which is from Associate Professor Michael O'Sullivan from the University of Auckland. Welcome, Michael. Looking forward to your talk.
Thanks, Karina. I'll endeavour to share my slides. All right, hopefully you can see all those. How's that?
Perfect.
Yeah,
great.
Cool. Kia ora koutou. So I'm going to talk today on a project that I've been doing as part of the Global Partnership on AI, and that's looking to build an AI-enabled framework for transferable pandemic modelling. If that sounds a little bit strange, hopefully as I go through my talk, it'll become clear what this means. So first, I'll just introduce myself. No ara ni me hana oku tupuna, ko Sullivan toku whanau, ko te aratu toku hapori, e naho ana o ki ngā whenua me ngā waitapu o te Tairāwhiti, tina kamihi, tina koto, ka mai ka hau. So I'm Michael Sullivan, Associate Professor in the Department of Engineering Science at the University of Auckland. In fact, we're now Engineering Science and Biomedical Engineering. I wear lots of hats, and the one that's probably the one that's relevant to this is I was part of the AI and Pandemic Response Working Group in the Global Partnership of AI, which has since changed, but that's probably the longest story they have time for here. So I'll leave that one for now. GPAI, the Global Partnership of AI, has just actually joined in a partnership with OECD. So in 2023, it had the member countries you can see there on the right, which includes New Zealand, and had a lot of member experts. And so I'm one of those member experts, and I've been leading a project. I've been leading a project called Pandemic Resilience, and this is where Pandemic Resilience sits. So the AI and Pandemic Response Sub-Working Group was part of the Responsible AI Working Group. As the pandemic eased, we were then brought back into the RI Working Group. And so you can see those are the projects that the Responsible AI Working Group was doing, and the Pandemic Resilience is one of those. We sent out a report, so that might be a little bit smaller text. We're one of 8 reports in 2023, which is talking about the work that was done there, and that was presented at the summit in Delhi. And the recommendations that came out of that report was really that decision makers need to be connected to modelers, and I think we saw that within Aotearoa New Zealand during the pandemic. But the recommendation is that this is done everywhere and done not just in response to crisis or not just in response to pandemics, but part of business as usual decision making in government. We're looking at how can you use ensemble models, and so the idea of an ensemble model is you have multiple models for a particular problem. Who knows which one is right? So you might want to consider all of them at once and consider how can we take information from that ensemble of models to help give us better information than any one of those models by themselves. Make sure that everything we do within the AI space is done responsibly, and I'll talk a little bit more about what that means shortly. Build capacity. So I was part of the Te Puna Matatini group that responded to the COVID pandemic. And I would say Aotearoa New Zealand was lucky and it had capacity to do that and do that quickly and a willingness to do that. And other countries maybe don't have that capacity, or maybe learnings from places like Aotearoa New Zealand could actually be transferred easily to countries, for example, some of our Pacific neighbours. A few of those other ones I'll skip over a little bit. Obviously, models need to be, or models that inform policy need to undergo maintenance and review. But probably the key, the next three actually, I think, using ensemble modelling as part of pandemic preparedness, I think is useful and important. It needs to be tested. So one of the things we're looking to try and do with this project is maybe do what's called a tabletop simulation, where we have our models ready to go and people sit around a table and pretend that there's a pandemic, or maybe replay what happened in the pandemic. And then also the idea of having a standardized pipeline for public data. And so we're using an Oxford data set that is an incredibly great data set. But I think, data needs to be, or public data needs to be made readily available and easily available, and so I've been doing work in other areas where that's the case. And I would say actually around health data in New Zealand, it's not too bad in some areas. So what we did in pandemic resilience was, the idea is that when you're dealing with a pandemic, it's complex. There's lots of uncertainty. If I do this, what's going to happen? So if we put mask wearing as compulsory on public transport, what's that going to mean for spread? What's that going to mean for people using public transport? So there's lots of different ways that interventions can interact with society. Also, because it's a pandemic, then this scenario is playing out in lots of different countries around the world. And so in that case, you don't necessarily know how the pandemic spread is really going, because each of those different countries have different cultures, have different societies. And so there's a lot of noise, even though the pandemic is progressing, the disease is progressing in each country, how it progresses is quite different. And some of that is the disease, and some of that's just how the country works. Also, there's a lot of balancing of different objectives. So I think we saw it here in Aotearoa New Zealand, is particularly when we were trying to open up just before, not Delta, Omicron came along, where the balance between keeping people safe and healthy versus making sure the economy keeps going is a really tricky one to figure out. So because I'm a modeler and because I was involved in modeling more around the health system in the pandemic, I believe that data-driven decisions are important. I think using models to try different scenarios is also important. And so I think we saw that when Jacinda Ardern put up that graph with sort of, what was it? It was optimistic, pessimistic, and likely, with 3 different scenarios. One of the other things that I talked about earlier is, who knows which model is right? So actually, if we have access to lots of models, maybe we should listen to all of them and find out a way to determine what we think the best course of actions might be, given lots of information from lots of models. And we also want to make sure this is done in a responsible way. So we do responsible AI best practices, and that's sort of summarized below, about being human-centered, fair, equitable, inclusive, respective of human rights and democracy. And I think where this project really is based is aims at contributing positively to the public good. So we're looking to provide these models to the public to help decision makers, keep people safe, make sure economies keep going, etc., etc. This is what it looks like, or at least this is what sort of happened in various countries throughout the world. So at various different locations, There are some parameters that were global, so things like what's the reproductive number of the alpha variant of COVID. There's some location-based parameters, which might be what's the density of the population at the location. So, for instance, Singapore versus New Zealand have similar populations, but very different population densities. And there might be some parameters that were around particular models developed at particular locations. So, for example, one of the groups we're working with is Cognizant, and they were working predominantly in the US. So they have a state-by-state neural network model, whereas the model I was involved with is a continuous time Markov chain model that's developed here in New Zealand. And so we have different parameters. So these models take the parameters, took input data, ran the model, made predictions, validated those against output data, and then depending on how accurate we were, maybe those parameters calibrated. So this was happening in multiple locations around the world with multiple different modeling teams. So this is, this was good, but that information wasn't able to be shared easily. And I think there was also, some at least discussion and probably disagreement about things like, for example, global parameters. So what we're trying to do in the Pandemic Resilience Project is this. So we standardize what the global parameters are. So we're all going to agree what the reproduction number is of the alpha variant of COVID across all of our locations, because that's something that shouldn't change. We will use standard parameter locations. So I will use the same population density in Singapore in my model than someone else would use in their model. I may use different model parameters. So I may have different tuning parameters for my model in a particular location than elsewhere. And then we'll run all the models in all the locations using these standardized data sets. We'll validate them against the output data, and then we can use the accuracy of the models either separately or ideally combine them into an ensemble, and then we calibrate the ensemble in the same way in the locations, in the same way globally. What this means is that for things that are persistent across different locations, or things that are persistent in a location across different models, the information we use about what that parameter should be, we're getting more information from each of the models rather than what I showed in the previous slide, which is everything is happening in isolation. As you can see from the slide, this gets a little bit complicated, but we've actually created a framework to be able to do this. And I'm just going to talk really briefly about the framework, but I'll talk a little bit about some early results. So some early results we had around, so LSTM as a neural network model showed that ensembling is quite useful. So if you did a random sample of the conditional LSTM and the LSTM and use that as your prediction instead, you actually got less error, because the conditional LSTM was good for some parts of the disease progression, the LSTM was better for other parts. And so if you got lucky, you got the good part. If you got unlucky, you got the bad part. When you combine together, you got more information. I probably don't have time to go through this slide in detail, but that's essentially what we're trying to do with lots of different models now. And a little bit, some of our models are really useful if there's not much data, and some of the models like the neural network are really useful if there's lots of data. And this is just an example of how it works. So we define a standard for inputs around global inputs, location inputs, and then this all goes into a JSON file that we use to feed to our framework and all our models. And then we calibrate it. So there's a lot of graphs on the slide. So essentially what you see on the left is a short calibration run, and I'll show you zoom in a minute. And what you see on the right is a longer calibration run. And what we showed is by calibrating these models over longer periods of time, we can make them more accurate. And so if we just consider, and you notice here I'm doing this for Kenya, Aotearoa, Sweden, and in the UK all at once. So we're building models that agree on parameters across those locations all at the same time. And the one on the right is about rankings. And I think in the interest of time, I'm just going to skip it. Here's what it looks like for Aotearoa and New Zealand. So you can see here, there's lots of, these are the different types of models we have. The dashed line is the ground truth. There's our neural network models, some cyber physical models, which are done with control feedback theory and the continuous time Markov chain models. The error is about 90,000, which is not great for a short calibration run. After you calibrate it for a bit longer, which is about a day, a bit less, we've got the error all the way down to about 800. Using exactly the same process, but changing the JSON file, we can go to a new case study. So this is one for New Zealand and Sudan, but starting in June. And if we look here, you can see this is the previous model for New Zealand from April, and this is the model for June. And we've now got the error down to about 10. It's still not super close following this, but actually this pattern, this numbers are so low, this is really difficult to follow. But what that shows is really just by changing the file, rerunning the code, you can calibrate an entire new model really quickly, again, in different locations and maybe for different modeling horizons. So people have done this by hand. We had a bit of a look at the the cyber physical one by hand, and you can see here. So actually, if you look up the top right, it was pretty good to start off with, but then later on it got really bad. And it turned out, and I thought maybe it was just Sudan, but actually it was really bad in New Zealand too. And this was a sort of unexpected long-term effect that this earlier manual calibration didn't take into account. And this slide on the bottom here just shows that initially the manual one was good, but it pretty quickly got worse, as did the neural network actually, and the CTMC models were better. So this is showing that there is some value in this automated calibration, because you can look over a large time duration and sort of in a way that people can't. And so I would say that this is sort of my AI side of things. This is AI calibration. Okay. So just to wrap up, what does this mean? We think this is a good opportunity for governments to add this sort of approach to their pandemic preparedness, or just their preparedness for anything toolkits. You can do lots of what-if simulations. So what if we put mask wearing? What if we put lockdown? These sorts of things into account. You can also move from prediction. So we can say, not only do you say, well, if we did this, this is what happened. We could say, what was the best thing to do if we want to, for instance, control outbreak, but also keep the economy reasonably okay. Other diseases can be used with different models for how those diseases progress. And we think this approach could have a real impact on decision making, because it's kind of providing an evidence base, but you're also not putting all your eggs in one basket with a single model. And you're using as much data as you can, not just from Aotearoa, New Zealand, but around the world. Thanks very much. I think I managed to catch up a bit of time from Ali. So I guess that's 2 minutes for questions.
That's right. Thanks so much, Michael. That was awesome. Any questions? Barry? You've always got a question.
No, I don't. Thanks, Michael. Great presentation.
Yeah, that was fantastic.
Yeah,
Okay.
no worries. And this, if anyone's interested in this work, please get in touch. This work is the funding for GPay is pretty much finished, but we're just wrapping it up, trying to add the economic model, and then we'll publish it hopefully next year sometime.
Thanks, Michael. We actually do have one question from Phil. I don't know if you can see it. Thanks so much, Phil. Good to see you online. Phil says, I assume it would be even easier / more accurate to predict the impact of policy initiatives, such as raising speed limits or reducing tax on smokeless tobacco?
Yeah, in theory, yes. So in some other work I'm doing, we're looking at sort of social models and using large data sets like those in the integrated data infrastructure to have a look at how policy initiatives may have an effect on society. So I think the idea of, speed limits and public health initiatives, I think are really a great place to test this sort of stuff out. I mean, I think there's still a lot of work to be done to get those societal models correct, but also there's so much data in there, and there's a great way to test things with cohorts. I think it's an approach we should be moving to, and I think government needs to be using, model informed decisions as at least one of the evidence bases that they use. And it's a lot cheaper than going out and doing everything like with surveys, and not to say we shouldn't do surveys as well, but I think it's a lot cheaper to do a virtual pilot with a model than it is to do an actual pilot in real life. And so it kind of sometimes de-risk what we do.
That's awesome. Thanks, Michael. I think someone else has asked for your contact details. So looks
like
there might be the start of some collaborations. Thank you so much, Michael. So we'll move to our next talk, which will be Dr. Robyn Whittaker. Welcome, Robyn. Robyn is a public health physician and the Director of Evidence Research and Clinical Trials in the Service Improvement and Innovation Directorate. Over to you, Robyn.
Kia ora koutou. Sorry, can you see and hear me all right now?
We can see and hear you, and you might want to put your slides on slideshow.
Oh, I've got them sharing. Are they not sharing?
You are sharing them. They're just still, yeah.
Ah, there we go. How's that?
Perfect.
Wonderful, thank you. Kia ora koutou, and thanks very much for this opportunity to talk a little bit about what we're doing in terms of AI within Te Whatu Ora, Health New Zealand. In terms of, I've got lots of hats, as most people do. In terms of AI, I just like to say I'm really not a technical expert like our last couple of speakers, but I am the chair of our National AI and Algorithm Expert Advisory Group within Te Whatu Ora. I've been on a WHO group around ethics and governance in AI and healthcare, and also the advisory panel that Ali talked about earlier, which I'll also mention. So, of course, what we're trying to do is to work out if we can try and make things better with AI within our health service. And some of the things that are being used currently, that are commonly being used in health services around the world, I'll just give a couple of quick examples. One is around predictive algorithms. I'm sure very familiar to most people in this audience. One of the ones that we use, we still can't get away from our COVID examples, can we? But was a COVID risk of hospitalisation score that was used during the Omicron wave when we had a reasonable amount of data from Delta, and we knew that we were likely to be overwhelmed with people with new cases of Omicron, and that we would not be able to contact them all rapidly. And so we developed a risk of hospitalisation predictive algorithm based on all the data that we held on people in the northern region in the health service, and we were able to present that data on the dashboard that the community services were using when they were triaging and phoning people. So that would actually help them to triage those people most at risk of severity and risk of hospitalisation, and also gave them a bit of information about why that was so. So those kind of predictive algorithms are starting to be used a lot. The other things that are being used a lot is imaging, using computer vision. So in radiology or in here, this is retinal screening. So the computers are obviously a bit better than the naked eye at picking up abnormalities and changes down to the pixel level. And so AI algorithms to identify abnormalities in imaging is starting to be widely used in health services. And then the more recent area really is around some of the generative or summative AI type tools. NABLA down the bottom right there is a tool that's being used quite a bit in primary care at the moment. Basically listens into a consultation and then provides a summary, a structured summary, a clinical note at the end of that consultation immediately, that can then be reviewed by both the GP and the patient together to go through what was discussed and the action plan, and check that they both agree that that's what happened. And on the left there is producing tailored consumer information for people very quickly based on whatever factors you want to give them, including language and level of health literacy. So those are the kinds of uses that we're seeing. This is the report that Ali referred to earlier, which has very helpfully given us some ethical principles, which he has talked about. But also, as he explained, goes through some of the opportunities that are before us. But we know that there's also lots of risks that come with those opportunities. And these are just some of the well-known ones which have been in the media over the years, particularly around bias and racial bias and minority population bias, but also around privacy and confidentiality of health information. And also around hallucination and inaccuracy of information that's produced by AI tools based on data. So these are some of the things that we need to be very aware of. And now that with the publicly available generative AI tools, that suddenly really blew out some of the risks and expanded some of them. And Ali's talked about some of these as well, but particularly around inaccuracy and confabulation, lack of transparency, and issues around data sovereignty and intellectual property. So when these publicly available generative AI tools suddenly became available and people were using them, we actually gave advice to staff of Te Whatu Ora not to use them, not to use them for certain things, not to put personally identifiable health information into them, because that could end up being a privacy breach, and not to use them, not to rely on them for clinical decision making because of the risk of inaccuracy. So we're constantly reviewing that, and I'll talk a little bit more about that as well. But so what we have been doing, actually for about 4 years or so now, is looking into how we govern the use of AI tools within healthcare services. So we've set up a governance group. We have a group that I will talk about in a second, but has been going. It started off as a Waitemata group and has transformed into a national group now. We have developed a process, so basically a checklist and an assessment process for people who are wanting to utilise AI tools within our health services. And then we've also established a bit of a virtual AI laboratory within Te Whatu Ora, which is looking into tools and enablers and developing up some people who can actually do and develop AI within our health service and within our health data. So those are kind of the 4 areas we've been working on. So firstly, with governance, this has got a terrible acronym that no one knows how to say, but basically it's our National AI and Algorithm Expert Advisory Group within Te Whatu Ora. It actually has internal and external experts on the group, bringing a representation from all of these areas here. So it's a very broad membership. It's quite a large group. It's difficult to manage. I am the chair and I have to do that. But we receive proposals for people who either have an idea and want to develop an AI tool, or for people who are trying to implement an AI tool within our health services. So we really like to be available to see people at both of those points to provide early advice on how to develop something well as part of the endorsement process before people are given access to data, or before they're given approval to purchase something, or before they actually implement it in real life. So we do consider that kind of full AI life cycle. And we did work up some years ago now a checklist for our own use that has been published in NPJ Digital Medicine, although we have updated it a couple of times since then. Well, this is just a bit of a summary of our process. As I've said, I won't go into that. That's how we're trying to get ourselves in at 2 points in the process early on, and also as part of the final approval process. So the things that we go through, I just thought people might be interested in the type of questions that people get asked in this checklist and how we go about looking at it. There's always the first question of, is AI even appropriate for this problem? And that's even where a lot of people stumble, because if they don't really have a good understanding of the problem and how AI is going to help that, then that often is a major issue in their development. But also just whether the data that would be necessary for an AI solution is actually appropriate, accessible and available, etc. And then for things that have been developed elsewhere and people are trying to sell us, it's more about how has it been tested. With LLMs, we've added in a lot more questions around how will patient privacy and confidentiality be preserved. So one of the reasons why we developed our own checklist rather than using an international one was that we didn't really feel that patient perspectives were well included in international checklists. And so we've added in a lot more around getting people to show some clear benefits for people, getting them to identify potential risks. And there's often a bit of a playoff between who's going to bear the risk and who's going to get the eventual benefit from it that people need to be aware of. But we've also conducted some research ourselves with Dr. Rosie Dobson around patient perspectives on the use of AI and the use of their health information to develop AI tools. So we use that to guide us, and that showed us really that generally people were very happy for us to use health information to develop AI tools, as long as it was for the public good. And as long as that we were maintaining their privacy and security of their health information, but also that they wanted us to be much more transparent and communicate a lot more about what was going on in that space, which we are trying to do. And then the second reason, of course, why we developed our own checklist was that Māori perspectives were not included in international checklists, and not even other Indigenous groups were not included either. And so we've added in an extra lens, which is around the Māori lens. We had some people do some great work adapting Maui Hudson's framework. So Kerry Hine and Prageeth Jayatissa did some work developing further questions based on that work. around really ensuring that AI is being developed in a culturally safe manner with some Māori governance and input and clear benefits for Māori and consideration of data sovereignty principles. I think with LLMs, there's even more considerations now that we haven't really fully got in there, got well nailed, which are around the impact on Mātauranga Māori and safeguards to prevent any negative impacts on that and on the use of te reo. Equity is a separate consideration, and that's really looking at bias, particularly around minority groups which may have minority data, but also around historical biases in our data related to the way that people have been treated in the health system in the past. And we need to ensure that we are constantly testing. We're basically asking people how have they tested for bias in their outputs, and asking to see the results of that kind of testing and what their mitigations are if they are discovering any biases in their outputs, and ensuring that we're not contributing to further inequities. We found clinical perspectives actually to be really important because we've found so many early developments have not really thought through how is this going to be used in the real world once you've developed it. They get so excited about what they think they can do, but have not really well thought through how are they actually going to use it in the real world and what are the upstream, downstream impacts on clinicians and on the workflow. Are clinicians going to understand it? Are they going to trust it? How are they going to use it? How are we going to train them? What is the impact on the patient-clinician relationship? And we have an underlying principle which comes through all of those principle documents, which is around retaining human autonomy. That is the way our medical system works at the moment, so that's still very important. So we're generally requiring them to show us how humans have the ultimate decision-making, and that AI, at this stage anyway, are still being used as decision-making tools. Data, of course, is really important, and I don't really need to talk to this audience too much about that, I'm sure, but there are lots of issues there around the data quality, appropriateness, privacy and confidentiality, re-identification, and again, that principle of transparency. We do require third parties, even if they're commercial, to be very transparent with us about what data was used in the development of the AI, what was the population it was based on, and what data was used, has it been tested on since then. We're also interested in getting those outputs into our environment as well. We've come across some really interesting legal and contractual issues, so it's been quite important to have legal representation on our group. Some interesting ones have been around accountability and liability. Who is accountable if the AI fails is a big one. What is the responsibility of the clinician versus us as an organisation if we're purchasing an AI versus the vendor? And what is the responsibility for ongoing monitoring and audit? So we're having to be really clear about those and put those into agreements. And yeah, just for people's awareness, there has been some really good information put out by the Privacy Commissioner around AI as well. It's well worth reading. And so I'm trying to show that basically the technical accuracy for AI is actually only one really small part of what we assess. I know most people, that's what they focus on, but it's really only one aspect. How we test for accuracy is very much dependent on the type of AI, and Ali has mentioned earlier that we actually don't really know very much about how to test for the accuracy of Gen AI. That's a really big bit of work that we're hoping to do with a whole lot of the academics across New Zealand. But we do require that we can test any new AI on our own data, and we will do that for people rather than give them the data. We will test their AI tools on New Zealand data within Health NZ, and we have a team that will do that, and that's a really key part of what we do. I'm trying to get through this really quickly, sorry. Ethical issues, of course, are huge, and this is the WHO group that I was on, what they produced around ethical principles, and I've mentioned the two really important ones which are a little bit different from other areas of ethical principles. One is around transparency and one around retaining human autonomy and decision making. NEAC standards have been really useful as well, and I think those are being updated at the moment. Just a couple of other points about transparency, and you may have seen that with Ali, we put out a bit of a note recently to say that perhaps we should be having a register of AI tools used within the public health system. We are currently maintaining one ourselves, but there's a lot more that's being used outside of Te Whatu Ora. And just for people's awareness, again, that there are recommendations around reporting the use of AI and around guidelines for and checklists for research being written up around this. But we're doing a lot of work internally as well, as I've said, under John Herries. He works in data and digital and is doing a lot of the enablers and platforms. And we are looking at testing our own generative AI tools so that they can be more private and secure, so that then we could let our staff use these kind of summative AI tools that I talked about before that summarize a clinical interaction. Because they're not publicly, one of the biggest risks is the potential for a privacy breach. So we're not knowing where that data goes, but we could have an internal one within Te Whatu Ora, and then our staff could use it in a much more safe and secure manner. So that's one of the kinds of bits of work that we've been setting up. We've been developing a little bit of a community of practice of people who are doing this kind of work within Te Whatu Ora. And I have a clinical lead in my team, CK Jin, who is the main connection for people who are wanting to do clinical AI tools within our system. And he is developing stuff. He's working with clinicians. He's working with radiology quite a lot at the moment about some tools that they want to put in and helping to develop them or helping them to work out how we're going to test them if we are going to purchase them. So, and that has been things like doing massive retrospective tests, so running a big retrospective data set through an AI tool and comparing that with what otherwise the results were, which, as I showed you, diabetic retinal screening in the beginning. So that's comparing against the diabetic retinal graders, comparing against what they said the outcomes were with the AI tools to see how well they worked. And then one of the other tools we've been using, is particularly for radiology, is around silent testing. So with radiology wanting to put in a tool that's been well proven and well used overseas, what we're trying to encourage is doing a silent test for the first month or so. So basically we're running the AI but in the background, and the clinicians are not able to see the output. And then at the end of that time, we're able to compare with what the radiologist said with what the AI said, without it influencing the radiologist at the time. Before we turn those things on fully. So that's the kind of testing we've been doing. And these are some of the current bits of work that are happening within our virtual AI lab. These are some of the different areas that we've been working on. As I've said, the machine vision, the generative AI, and the risk prediction algorithm type scores. So that is a very quick run through, but I'm very happy to take some questions. And I think, one of our big lessons has been that it's all about how you do it, not what it is and how accurate it is necessarily, but it is about how you want to use these, but also about ensuring that we're using them for the right things, things that are actually really going to make a difference, make our clinicians' jobs easier and provide good patient care. So kia ora koutou. Thanks, Karina.
Kia ora, Robyn. That was fantastic. Clearly a large program of work. We have a question from Tim. Kia ora, Tim. For those of us that work in Health New Zealand, how can we get updated on the good mahi that you are doing?
Oh, thanks. Yeah, that's a good question. So for those who work in Te Whatu Ora, you may know that we don't have great communications at the moment. So yeah, we're trying to get this all up on our intranet, but it's been slow work trying to get that to happen. But yeah, we have prepared a whole lot of content for the intranet, which is around who's on the expert advisory group, what projects have we been working on, what proposals have we had, and kind of rough outcomes of those. So I don't think that's live yet, but hopefully that should happen really soon. But otherwise, you're welcome to get in touch with myself or CK Jin or John Herries. I can put our contacts in the chat after this.
That'd be awesome. Thanks, Robyn. Are you able to stick around for like 5 to 10 minutes just in case there's more questions? Thank you so much. Thanks, Robyn. We'll move to our next speaker now, Rooshan Ghous from Whitecliffe College. Welcome, Rooshan. Looking forward to your presentation.
Hi, Kia, everyone. Are you able to see my screen?
We can see your screen. If you could put it on slideshow, that'd be great. Thank you.
Thank you. Secure everyone. My name is Rooshan, and I'm excited to present our current project, which is development of a machine learning model for long-term survival prediction of patients diagnosed with breast cancer in New Zealand. It's a part of my master's project at Wycliffe College, and it's supervised by a fantastic data scientist, Dr. Bin Thang Dang. So currently we are midway in our project, and today I'll just share the overview of what we are doing, some preliminary findings that we got from our pilot study using SEER data, and I'll also share some exploratory data analysis that we got from New Zealand breast cancer data. So as we all know, breast cancer is the most commonly affecting cancer in women in New Zealand and globally. It's the third most prevalent cancer in New Zealand, and 1 in every 9 women receives a diagnosis of breast cancer in our population through their lifetime. So there a lot of good work has been done in both in public health and in research to understand the short and medium term risk factors of breast cancer and its prognosis. But as Breast Cancer Foundation states, a lot of work needs to be done in long-term survival prognosis and understanding the risk factors involved. So this is where we can try and help. So I'll start with a case study. This is Olivia Munn. She's a Hollywood actress, but I came to know about her through this post by Breast Cancer Research Foundation. Later, I found her case has also been shared at major news platforms like BBC and CNN. So Olivia had a risk of developing breast cancer because of her family history. She had her mammograms done and she had her gene testing done for BRCA1, BRCA2 genes, both of which came negative. So she was with her clinicians, and her clinician is an advocate of using risk assessment tools. So our clinician suggested that they do a risk assessment by asking some simple questions. After a few questions, they found that Olivia's score was really high for the risk of developing breast cancer. So the cutoff score was 20 and Olivia scored higher than 37. This prompted a series of tests, including MRIs, ultrasound, biopsies, and 9 months later, Olivia now has had 4 major surgeries, including a double mastectomy, full hysterectomy, a full oophorectomy, a hormone-induced menopause, and a vigorous chemotherapy. So all of this was because of her aggressive cancer. It was a bilateral luminous B breast cancer that was missed by the gold standard of screening, both mammograms and BRCA1 and 2, which is often used to determine risk of breast cancer, but it was picked by a simple risk assessment tool, easy to use and available. So I think this is how value of these tools can work in some situations. So why do we need a local survival prediction tool? So there are tools being used in practice in US and UK. UK actually has a tool that's used in routine in their oncology department. It's called Predict UK. In New Zealand as well, some clinicians use it. However, we need a tool that's developed on our population. As we know, AI-based tools are highly sensitive to the population on which they are developed. So developing a tool based on our New Zealand data can help identify survival time precisely. It can help with favorable treatment plan, triage for treatment and screening, decreasing the workload of clinicians. It can also assist in public health policy making and reducing the ethnic disparity that inherently exists in health outcomes of cancer patients. For this, I like to take example of skin cancer. So we have the highest rate of skin cancer. But if we use a tool that has been developed in a country that hardly sees the sun, or where people remain mostly indoors, it won't work for our population. We love outdoors. We have a very high UV rate. And we have a predominantly European population with a distinct genetic makeup. And so we need, similar to skin cancer, we need our local prediction tool for breast cancer. So research objectives for us were two main research objectives were to develop a long-term survival prediction tool using machine learning, and we are looking to develop a 15-year tool. And our second objective is to identify the temporal variation that may exist within risk factors. So the risk factors, as the time progresses, their importance can change. So if at the time of diagnosis, surgery is important, radiation therapy might be a more important predictor for long-term survival. Similarly, genes and other risk factors are time dependent, like they can gain more importance or lose importance for survival prediction. So one of our objectives is to look at the temporal variation that exists in the risk factors. So this is a brief overview of our study, a pilot study that we use doing SEER data. It's an excellent source of data. It covers about 40% of US population. It covers almost all the ethnicities. It is representative of the general population. We started with a total of about 270,000 cases that were diagnosed over a period of 5 years, and we followed them for a period of 5 years. We excluded cases of Mets and other genders. So, and that is because breast cancer is mostly prevalent in females, and less than 1% cases are in males. So we applied a number of machine learning algorithms to assess how they perform on US data. We used supervised machine learning, ensemble learning, and deep neural networks. And this is a brief overview of our results. We found XGBoost as the best performer in terms of area under curve. Then we used some extra validation matrices to check if our results make sense. And again, XGBoost performed slightly better in accuracy and precision. Decision tree did pretty well in recall, and F1 score, for F1 score, deep neural network was the best. So now we are at our main, we have started our main project, which is developing the tool for New Zealand dataset. We acquired the data from Breast Cancer Foundation National Register. It was a long and complex process. We had to defend our cause, and we have to provide evidence that the data will be in good hands. So it took us a few months, but it was an honest process, and we are so happy and privileged that we got the data from the foundation. The inclusion criteria was all the women diagnosed between 2002 till 2017. Patients lost to follow-up, and those with Mets at diagnosis were excluded from the study. We actually are dividing our cohort population into 3 subgroups, and that is to validate our results. So this allows us to conduct internal, external cross-validation. So the register collects an amazing set of variables. It looks into a large variety of risk factors, and we are not sure if we can find similar variables in other data set that we can verify our model against. So we use this approach where you divide your data by time period, and you can assess the results, validate them against each other, against each cohort. So this is a brief data summary. The included cases were about 22,470. The register collects amazing amount of variables, around 400 at this stage. We requested around 230 predictor variables and 65 that were related to outcome and follow-up. This was initially taken to look at the shape of the variable, how much was degree of completeness, how they could be used with or against each other. So this is how the data looks like. We collected data before 2020, so it was before the inception of National Register. Firstly, it was just Auckland, then Waikato came on board. Christchurch joined in 2009, and now we have data from Wellington as well. This is a simple histogram of age distribution of the overall population. But this is histogram of age distribution, age at the time of diagnosis. So this is age at the time of diagnosis of cancer. And you can see there's huge difference between the distribution at age of diagnosis between populations. And we know age at diagnosis is a critical factor for cancer prognosis. So we are developing a multi-factor risk model, and broadly we can divide our risk factors into 7 categories, including patient demographics, clinical presentation at the time of diagnosis, radiological features, histological features, including biomarkers, stage and grade of tumor, tumor characteristics, including hormone receptor status, ER, PR, and HER2, treatment received by the patient, including hormone therapy, chemo, radio, and biologic therapy, and histopathological details. So at this stage, we are looking at feature importance. It's a process in which you analyze when you have a large number of variables and you want to make sure that they add value to the model and how important they are for your outcome variable. For us, the outcome variable is long-term survival rate. So you can run a feature ranking analysis that helps you understand how important the variable is. For us, we want to see how important the variables are over time. We used XGBoost and we also used Random Forest, but the better results were from XGBoost. It has the ability to handle complex nonlinear data that inherently exist in cancer. It also has the ability to understand different types of data. For cancer, we have histological type, we have clinical symptoms, and so a wide variety of data, and XGBoost has ability to understand and handle those complex relationships. And this ability is, here I'd like to defend AI. So this ability is not possible, although survival prediction has been, is ongoing since about 40 years or more than that. But artificial intelligence has the ability to understand the complex relationships. It can decipher the non-linear relationships within data. That's not possible with traditional statistical modeling. So these are the results that we got for 5-year survival analysis using XGBoost. This is just for feature ranking, and it's not definitive. We are work in progress. So we used a total of 60 predictors for this analysis. This graph only shows the top 20. The choice of those 60 predictors were based on their importance from clinical knowledge. And also one of the factors we took into consideration was degree of completeness. We didn't want to imputate the data. We didn't want to replace any missing values at this stage. We wanted to use the complete data to see what value our predictor brings. At this stage, our data had a high degree of completeness. I think the lowest was around 70%, which was very few variables. And most of the variables had a high degree of completeness between 90 to 100%, which was amazing. And this analysis is not complete because we dropped some important factors from this particular primary analysis, such as BRCA1, BRCA2 genes and family history. And that's because those two variables has just been started collecting by the register. So we didn't have a lot of data for those. We'll conduct a separate subgroup analysis for those types of variables. And an interesting finding is, so we ran this test on all 3 cohorts, and we saw that when the cohorts changed, the feature ranking changes. We also did the analysis on 6 months, 1 year, and 5 year, and we found that for different time periods, the risk of each factor changes. Not hugely, because it's only 5 year, but slightly, especially the factors in the middle seem to change their ranking over time more. When we did the similar analysis on SEER, we looked at 5, 10, and 15-year prognosis of our cohort, and we found the risk factors significantly change over time and feature importance. For example, surgery seems to be important in 5-year analysis, but radiotherapy jumps up the queue in 15-year analysis. Just some examples of how data, our risk assessment worked. So the results are steady so far. We are only midway through our research, but our study shows that risk factors do show temporal variation over time, and that's significant while model development and later in treatment planning. And we also found that models are highly sensitive to data selected. By changing the cohort, we found the feature ranking changed as well. So we need a population-specific tool to accurately predict breast cancer for New Zealand population. In conclusion, as we know, cancer is a complex disease with multiple factors affecting its outcome. Understanding their role is critical, and this is where artificial intelligence or machine learning can help. But it's only possible by use of good data and a team of multidisciplinary experts. It wasn't possible for us to do it on our own, and we are very privileged to have our clinical advisors on board. They make sure our interpretations and our data make sense. So we've got Dr. Robyn Broom, who runs clinical trials with University of Auckland. He's an excellent oncologist and a clinical researcher. Vanessa Blair, a breast surgeon and an avid researcher. Her research is mostly on understanding the types of breast cancer and their outcome. To ensure the ethics of our research, we've got a Maori integrity advisor, George. He's an expert in culture and capacity building for Indigenous people. Finally, I'd like to acknowledge Breast Cancer Foundation National Register for providing us with the invaluable data funded by New Zealand Breast Cancer Foundation. Also to Jane for her ongoing support. We sincerely appreciate our clinical advisors for their invaluable guidance. And finally, George for his input in the project. He ensures that our project aligns with the principle of Maori and Pacifica sovereignty. Thank you. If there are any questions?
Thank you so much, Rooshan. That was an excellent talk. We do have time for a question. If there are any questions that people would like to ask. We have a question here from, I think, Michael. Doesn't unstable feature ranking suggest overfitting?
Yes, so it does. It is. That's why our results are not definite. And it's also, there's so many factors to look at. So we are looking at different cohorts. And we actually substituted different features to see their ranking, and you are absolutely right. So if we took some treatment away and replaced with other, the ranking of other features changed as well. So it's very complicated, I would say, process, and definitely there's a risk of overfitting. So that's why we've got our cohort divided into 3 subgroups. So once we are done with our feature ranking and our clinical advisors can suggest if it makes sense, we'll continuously be checking with them. Then we'll validate our findings against our own cohorts to see how it performs. That's our strategy for now. Yeah, absolutely. Yeah, there's huge risk of overfitting. True.
Thank you so much, Rooshan. Are you able to stay on for the next 5 or 10 minutes in case there are other questions that come through?
Sure.
Okay. Thank you.
So that's my introduction, which I've already. So yes, until now, the prevailing view of AI developers is that if I can demonstrate that my AI performs well, people will trust it. So consequently, the traditional approach has been to test the algorithm in external data sets and see how well it performs on a population it has never seen. And the AI's performance would then be described using terms as accuracy, sensitivity, specificity, and the area under the receiver operating curve statistic. However, there are 2 fundamental flaws with this approach. Firstly, the metrics simply tell us how well the tool worked in the population. And secondly, physiological biomarkers are normally distributed and health data is often heavily skewed. The problem being that the population statistics tell you nothing about the results issued to an individual. And if the data is heavily skewed or normally distributed, the AI tool can perform surprisingly well if it simply guesses the mean or the most commonly labeled category. So consequently, a tool which is unable to discriminate between those who fall within the population mean and outliers may still appear to perform very well, when in reality it doesn't work in those individuals who you most need to know about. So to address these shortcomings, researchers have developed techniques that are designed to open the black box, so that we can understand how well the algorithm arrived at its decisions. Now, as a group, we have recently conducted a large systematic review of the techniques that developers use to explain how their tools work. Although, as shown in the graphic on the left, a wide variety of explainability tools have been developed, the vast majority, particularly when applied to retinal imaging, simply are variations on the same method, namely class activation maps. So here is an example of a class activation map, and the green dots in the center of the retinal image indicate what pixels the algorithm paid attention to when assigning this image to an outcome. So on the face of it, this seems an excellent tool, as it gives the clinician the opportunity of interrogating the image and thus understand why it was allocated a particular outcome. Although there are a number of technical limitations with this approach, the bigger issue is that it can only tell us which pixels the algorithm paid attention to and not how it used them. So deciding why the algorithm issued a particular result is therefore open to selection bias amongst others. For example, these are class activation maps extracted from an algorithm designed to predict mortality. In the top 2 images, the AI paid attention to very similar areas of the retina and yet came to very different conclusions. The person on the left was alive and the person on the right died. In this example here, the opposite is true. The algorithm this time paid attention to very different parts of the image and yet issued the same result. So faced with apparently contradictory data, it is thus very challenging to explain how the algorithm arrived at its results. So the growing realization that the methods developed and used thus far cannot provide us with an objective explanation of how the algorithm works has prompted us to look at how we may develop algorithms that are more transparent. So the traditional AI system is like this. It's an all-in-one black box where there is no visibility of how the system analyzes and sorts the images into the output class. So one approach to improve explainability is to use a modularized architecture with different subcomponents of the algorithm designed to spot specific features within the retina. Although these submodules are still black boxes, at least the clinician can now see what weighting the system gives to each submodule when allocating a particular output. In the case I see here, the algorithm is allocating significant weight to neovascularization, new vessels, ERMA, and venous beatings and loops. Now, as these are the same features that I would have paid attention to in this image, although I cannot tell how our individual submodule is working, I can at least be reassured that the algorithm system is extracting the same data from the image that I would have done so to make the diagnosis. So as promising as these explainability systems are, they remain user-dependent, as an experienced clinician is the only one who can really interpret what the AI is doing. And this somewhat defeats the purpose of deploying the AI system in the first place. So in addition to having a submodule architecture, we need a metric that doesn't just focus on the AI's output, but also comments on the confidence with which the system has on the result. Now, one way of doing this would be for the AI system to be able to compare your results with those issued by others given the same result. So in this example, every colored dot in the map represents individuals who've been issued the same output. Independent of this color code, we also have clustered together those individuals who share very similar biological profiles. Thus, if we look at the two blue dots I've highlighted, in the top case, this individual is clustered next to other individuals who share a very similar biometric profile to them. As such, we can be reasonably confident that the result issued to them is likely to be correct. Conversely, looking at the lower of the two dots, this individual has a very different biometric profile to those assigned the same output class they were. And in this case, it's perhaps reasonable to question whether the results issued are correct, and consequently the results issued by the AI system should probably be questioned. So bringing this part of my talk, or the talk, to land, well, I had hoped that we'd give you a brief introduction to the framework of what a trustworthy healthcare AI would look like, but I hope I've actually been able to give you an idea of what we as AI developers are doing to ensure that we can give clinicians and their patients the information they require to at least trust and test the results. I believe that if these strategies that we have outlined were to be adopted, they would not only enable developers to justify how the tools work, they would also reassure clinicians and their patients that the tool is applicable to people like them. So thank you. That's my bit of the talk.
Well done, David.
So there we are. Wasn't expected to do that.
I've never seen that work.
No, I wouldn't recommend that people try it.
You did that as if you were actually talking properly on the thing. How about that?
Right. Yeah.
Do that. Bring
Well so what we wanted to put that into the context was the fact that actually if healthcare, if AI is to be trusted, healthcare traditionally has a lot of trust. People trust healthcare, and we wanted to explore why people trust healthcare, but also that COVID has shown us that healthcare, even trust in healthcare, can be undermined. And particularly when we introduce new technologies, it's very easy for trust to be undermined in these new technologies if people start to doubt what it's doing. And really, as a clinician who's involved in AI, I'm aware that I need to be able to, if AI is going to be incorporated into healthcare, and if it's going to change healthcare in the way that we anticipate it might, people have got to trust that the results that I'm telling them from the AI are applicable to them, not just applicable to the population they happen to come from. So we need to be able to say with certainty, the AI shows this, and I can trust it that the result I'm issuing to you as an individual is appropriate to you. So that was the brief summary of the wider part of it all.
So does it get better with time? I mean, the more you do it, the better it'll learn, and those nuances that you actually found in the illustrations, that probability of those being, if you like, misread or whatever, will decline. So in 5 years' time, it'll be more accurate for you.
Correct. Those two, and it's the same for, I always like to say AI is a bit like a clinician. That's how I train my junior doctors. The first week in clinic, they're useless. they're pleasant, but they don't actually be able to. By the end of a month, they've learned quite a bit. By the end of a year, they can actually see and diagnose probably 70% of people. By the time they be clinicians, 5 years, they can experienced clinicians, they can do 99%. So yes, AI is similar, but it's all dependent upon the base data that's presented to it. And of course, that assumes that that there are other people in the population who look like you. So it all comes down to what's your population data set, who's in it, how representative is that of the population. But having said that, we've still got to get it to a point of how relevant is this AI result to you? Are you one of the outliers? Because in medicine, there are always outliers. And when I'm faced with someone in clinic, I can say, these are the results, but they just don't fit your case. I think there's another reason. So I want my AI to also say that and say that although the AI is saying this, I just don't think it quite fits you. So maybe we need to step back and say, maybe in this case, the AI isn't helpful. In the same way, I can say, actually, in this case, the AI is helpful. So I want some confidence around the result issue. But you're right, it will get better in time, but there's still that issue.
So one other thing, Karina, if I can just ask David. So the responsibility for the decision-making still stays with the clinician.
I would very much, we're a human-to-human business, really. We are a service industry, but it's about delivering information to patients. The AI, I think just having an AI tool tell you what your diagnosis is really unhelpful. Doesn't it? To tell you what stages is unhelpful, because you need that result interpreted. Well, okay, what does it mean to me? What does it mean for my family? What does it mean for treatment? The AI is simply a clinician support tool.
Well, thank you. Great presentation. Thank you.
Okay.
I mean, I definitely think you deserve an award, David, for remaining cool and calm and delivering a fantastic presentation. So well done to you. Barry, I'd like to hand over to you, given that this is the last session. Do you have any final words before we hand over to Peter to do the karakia?
Thanks, Karina. Yeah, just a word of thanks to all the presenters, both yesterday and today. Been outstanding presentations, both national and international ones. And I think it really shows that PHONZ is filling a definite need in the sector for people to exchange ideas, hear new ideas, just experience something different. And I think we've all learned a lot about health intelligence or health or data and things that we didn't know before. So thank you to the excellent presenters. Thank you to the chairs for a great job. It's always interesting chairing remotely rather than chairing face-to-face. So we're getting better at it. And thanks to the PHONZ committee, who've been incredibly supportive over my cajoling and pushing and shoving. But I think thank you for your support. And lastly, but not least, thanks to Patrick yet again in the engine room of the show, manages to come up trumps all the time and fix things. So once again, thanks everyone for a highly successful PHONZ conference. I guess it's now the task of the PHONZ committee to have a rest for a couple of days and then think about the next theme and start planning next year. But we'll have a rest for a couple of weeks and then we'll get back to that. But once again, thanks everybody for your participation and your encouragement and support of PHONZ.
Thanks, Barry. Peter, would you? Oh, is it Tim? Who's closing? Oh, thanks, Tim.
Naomi, thank you very much, Karina. Mi karakia tātou, kia whakataka ti tapu, kia wātia ati ara, kia tā kuru whakataka e, kia tā kuru whakataka e. Humi e, hui e, pai ki e. Ka pai, thank you.
Thanks, everyone.